Public now? Okay. Thank you, and we'll just check for public shortly. Okay, members, I declare that we're now in public session and declare the meeting open to the public and welcome members to as a member of the meeting of the Public Accounts Committee for this mandate, and advise members that the committee meeting will be recorded and broadcast through Parliament buildings and online. However, there could be a slight delay in moving between any private and public sessions, so please be patient with the system. Can I advise that those in the public gallery are welcome to use mobile devices as long as they are in airplane mode, and that all devices are muted. And if they need to connect to the Wi-Fi, they can do so by looking at the gallery rules. It is not permitted to record or take photographs of this meeting. We'll proceed as follows. Have we any apologies, Clerk?
Tom.
Okay, Tom Buchanan. Apologies. Okay. Draft minutes of the meeting of the 18th of April on page 6 to 11 of your pack. Members have had a chance to consider. All agreed? Okay, thank you. I've just signed these now because okay, thank you. Okay, members, in the tabled papers on page 3 is a letter from the Minister for Finance to the Audit Committee, copied to the Public Accounts Committee. The letter thanks the Audit Committee for preparing draft budgets for the Northern Ireland Audit Office and other non-departmental bodies. Can I ask members the content to note this correspondence? Okay, thank you, members. There's no chairperson's business in particular today. Declaration of interest. Can I ask members if they have any relevant interest to declare for this meeting?
I just declare that I have worked within one of the Trust's mental health services, and in particular in the crisis intervention team, because I know it's coming up.
Okay, thank you, Colin.
Just chair of the all-party group on autism, Chair.
Thank you, Cal. Padraig? No, we still have no volume.
I think his was chair of all party group on mental health.
Okay.
We'll cover your back, Paddy.
So just for the sake of record, the chair of the all-party group of mental health, Padraig Delargy, thank you for declaring.
Let me on now, Daniel. So just to confirm that, thank you.
Okay,
Sorry,
that's
Chair.
great.
I'm treasurer of the all party group on autism as well.
Okay, thank you, Cheryl. Busy group this. Okay, can I refer members to pages 5 to 40 of the meeting pack? There is correspondence received on the 23rd of April from the Mental Health Champion, Professor Siobhan O'Neill and Dr. Nicole Bond, providing further information for the inquiry into mental health services in Northern Ireland following the briefing session held on the 18th of April. The Clerk has shared this correspondence with the Northern Ireland Audit Office to inform the final PSE report. And can I just, again, on the record, thank Professor O'Neill and Dr. Bond for being with us last week for a very strong evidence session that absolutely has informed this committee before we initiate this important inquiry into mental health services today. Can I ask members if you're content to note the correspondence? Thank you, members. Okay, members, the next item on the agenda is inquiry on mental health services in Northern Ireland, or evidence session. And can I ask if we could check if our witnesses are outside?
You don't know. He's down the high.
Okay, thank you.
Oh, Harry.
Okay, thank you. Can I take this opportunity to welcome Mr. Peter May, Permanent Secretary for the Department of Health, Mr. Peter Toogood, Deputy Secretary, Social Care and Public Health Policy Group, Mr. Brennan Whittle, Director of Community Care, Strategic Planning and Performance Group, Dr. Petra Kaur, Director of Mental Health, Learning Disability and Community Wellbeing Services for the Northern Ireland Northern Health and Social Care Trust, Mr. Stuart Stevenson, Treasury Officer of Accounts. Stuart, you're very welcome back. And Ms. Dorina Carville, Controller and Auditor General for Northern Ireland. You're all very welcome, and all of our guests in the gallery are also very welcome. Members, in your packs are the relevant papers and, as discussed earlier, other items of interest. The Northern Ireland Audit Office report on mental health services in Northern Ireland at pages 17 to 73. The Northern Ireland Northern Ireland Audit Office brief on pages 74 to 82 of your pack. Witness biographies 83 to 86. Departmental preparations pages 43 to 49 of the table papers, which will have been discussed. Mr. May, Mr. Toogood, Mr. Whittle and Dr. Corr, you are very, very welcome to this Public Accounts Committee evidence session, the first of this mandate, and we're very keen to hear the evidence from you today on this all-important matter, which is mental health services in Northern Ireland, an area that touches the lives of quite a significant proportion of our population and families, and there will be a keen amount of public interest in this session now and in the weeks ahead. So we do appreciate you taking the time to come and meet with us, for your engagement today, for taking our questions, and for your appreciation of the severity of this very important issue. So I'll ask you to make a brief opening statement, and I say brief because the committee is very well versed and have taken the last number of weeks to consider the report from the Northern Ireland Audit Office, which is very detailed, and we're very appreciative of the work that they've done. And also, we have been discussing this at length. We received an evidence session last week from the Mental Health Champion, and we are keen to get to questions to ensure that we get the most time to get the answers that are relevant. Okay, if Mr. May wants to proceed.
Okay, good afternoon, Chair, and thank you for the opportunity to come before the committee. You've already introduced my colleagues, but I'd like to record that we welcome the return of the Public Accounts Committee and recognise the significance of having been called to its first session. I think I can confidently say that no accounting officer enjoys the experience, but we recognise that the PAC is a key accountability mechanism within government. I think perhaps it's important to start by just saying that I suspect on a number of the areas that we're going to discuss today, we will end up in violent agreement about the core approach needed to advance mental health. But the challenge will be how we deliver that in the current financial circumstances, with the budget outlook particularly for 24-25, which is extremely concerning. Those themes of agreement on direction and challenges of funding will, I suspect, recur throughout this session. We welcome the Audit Office report on mental health. It recognised the work the Department had done with a renewed focus on mental health, as evidenced by the Mental Health Action Plan in 2020 and the 10-year Mental Health Strategy in June 2021. The Audit Office also recognised the strategy would be the key vehicle for improving the situation and acknowledged the work being done to develop an outcomes framework to underpin the collection of data. Despite our funding challenges, we have made funding available over the last 2 years to take forward priority actions within the strategy, having listened carefully to partners about what those priorities should be. And I just want to briefly mention a few areas where there's been real progress. So firstly, a community perinatal mental health service now exists across the region with teams in place in all trusts. That was a service that didn't exist previously. Secondly, we have a 3-year early intervention and prevention action plan with progress made on the rolling out of emotional health and wellbeing teams framework in schools, with an initial cohort of schools identified and engaged, with 268 referrals of families to the early intervention and prevention service and 52 having completed the intervention, and with over 70 children and young people with complex needs having been engaged through individual and group sessions. We've also published an independent mental health workforce review with work underway to begin implementation. In addition, there's been over 2 million of additional investment in the Child and Adolescent Mental Health Service, or CAMHS, to enhance existing provision and alleviate pressures. That allowed us to increase the CAMHS workforce by 38 whole-time equivalents. We've completed a review on how to engage the community and voluntary sector, and we're working collaboratively with colleagues in the Republic of Ireland and across Northern Ireland departments such as education, communities, as well as the PSNI on programmes and initiatives. That recognises that solving the mental health problem is not just the responsibility of the Department of Health. Finally, on data, we've made significant progress. We've finalised the regional outcomes framework, which includes measures. They will help us to track how much we did, how well we did it, and is anyone better off as a result. Those measures are currently being embedded in the new Encompass system, and that will support the collection and analysis of data as Encompass is rolled out across Northern Ireland. We've also taken forward the recommendations from the Office of Statistics Regulation report, and following a recent review exercise undertaken by OSR, they've asked us to write a guest blog to highlight and make public the good work they consider we're doing in Northern Ireland, particularly around Encompass and the regional mental health outcomes framework. I hope that summary is helpful. We'd be happy to take questions from the committee that you indicated you would like to pursue.
Thank you very much, Permanent Secretary, for those brief opening remarks. There's a number of areas that you have touched on that will be of interest to members. I'm going to begin with a number of points. You've touched, first of all, on, and Diane will go on with this later, but because you've mentioned it, Encompass, and there's another system called EPIC. Why is there two systems being designed? What is the benefit of that? Why is that? What is the cost of that as well to the public purse?
So there is only one system. The Encompass system is the system that's being introduced. EPIC is the name of the firm that is supporting the introduction of Encompass and delivers systems along these lines in the US, in GB, and across other parts of the world as well.
Okay, so EPIC
is sometimes used interchangeably, and it can confuse, but Encompass is the system that we're introducing. That's what we're calling the system that's being introduced. It's being supported by EPIC in terms of its implementation and functionality.
Okay, and can they interlink with each other?
So EPIC is the firm that is supporting the functionality.
Okay, so just for clarity, it's not very clear just from what we're saying. That's
Apologies.
fine, I appreciate that. So, Permanent Secretary, there's 17,500 people on waiting lists at the minute in Northern Ireland in terms of mental health. Now, we'd argue, given the poor data collection and the failures of the system to prioritise mental health needs and demands, that figure would be much larger. There's many that are saying, many constituents of mine and other members of this committee that are saying they just cannot access services, that services do not exist, or if they do get access to services, they're being failed by those services. Do you think this is an acceptable position? And what actually has been done by the department in relation to those issues?
Thanks for the question. I think waiting lists is one of a number of important areas. So you quoted a number, which is, I think, the total number of people on a waiting list. For me, the key is actually the number of people who are not being seen within the time limits that have been set. There's a 9-week and a 13-week time frame, the 9-week for adult mental health and the 13-week for psychotherapies. It is a reality that the numbers overall have grown over recent years, and we are facing a demand and capacity gap in terms of mental health, and there's no doubt that the COVID pandemic has substantially made that worse in that we are seeing presentations now with much greater acuity than would have been the case before, and the consequence of that is that each individual, or that all of those individuals, will need more treatment and take longer, and therefore you're not having the same turnover of cases that would be possible otherwise. There are very substantial efforts being made to try to maximise the delivery of activity within the resources that we have, and we have seen increases this year. Activity is in relation to adult mental health is 15% above levels from the baseline year of 2019-20, that is before COVID. And for psychotherapies, there's been a 16% increase in the level of activity. Now, activity is one measure. It's also really important to have high-quality services. I'll maybe ask Petra in a moment to say a little bit about how quality gets measured within each trust, but there are robust quality measures as well. But even after we've had a focus on productivity and increased that level of activity, we still have waiting lists that are too long, and we all recognise that. And I'm afraid mental health is not the only area. You all know that is a problem in. And there's a reality here that we are going to need additional investment to address that problem. And for the last 2 years, we've faced very substantial funding challenges, and it looks as though this year the funding will also be incredibly constrained, and therefore it will be very difficult to make the investment that is needed in order to deliver the enhancement that will help to address waiting lists.
Just before Mrs. Corr comes in, just a number of points. You had mentioned the 9-week waiting period and the 13. So what's the numbers in relation to that? You said that there, in terms of people waiting.
Okay, so just one moment while I get those figures up. In relation to adult mental health and the 9-week target, there are 2,622 cases that have not met that currently. For dementia, which also has a 9-week target, there are 1,665 cases or people. For CAMHS, it is 1,104. And then for the 13-week psychotherapy breach, it's 4,845. So in total, you're looking at 8,000 or 9,000 cases where there's been a breach in terms of not meeting the timescales that are set.
And just in terms of the real challenges, and again, that this will be raised by Diane, if there's real issues in collating data here, and has been for a long number of years, how accurate are those figures in real terms?
We have confidence that those figures are accurate. There are some challenges in relation to data, and I'm happy to talk in more detail about what we're doing in relation to data, if that's useful. But we do have high levels of confidence about a range of the data, including those set of statistics. As I said, we have something called the Service Delivery Plan that the Strategic Performance and Policy Group within the department oversee, and they report monthly to me, as well as having detailed interactions with trusts around performance across a whole range, across the whole raft of different key measures, of which mental health is one, and we would have confidence in that data.
Do you want to come in, Ms. Corr?
It was about the quality aspects in terms of casework.
Across the 5 trusts in Northern Ireland, obviously there are a range of mental health and psychological services, and we have been working to develop, as part of the regional mental health strategy, a framework of outcomes that will allow us to measure more than just the quality and the volume of sessions that have been offered, because while that's important and the waiting times are important, it's really important that the intervention that is offered is A, evidence-based, and B, makes a difference. This is based on some work that I'm very familiar with that has been ongoing within our trust, within the Northern Trust, since 2016. So there's a very strong framework of evaluating the outcomes of all of the sessions of intervention. So for example, in psychological services, we measure the outcomes of each individual who comes through the services, and whether they are any better off or whether they have been impacted by virtue of the intervention that they've received. So we are able to answer the question, how many people are better off? And I can advise that in our evaluation of last year's activity within psychological services in Northern Ireland, or in the Northern Trust, we identified that actually 72% of the population had achieved a reliable clinical improvement, and that is actually a higher and better outcome than IAP services in England, which would be a benchmarked service, who achieved 69.5% of reliable clinical improvement within those individuals who used the services. So we're able to look at standardised measures of, for example, depression, anxiety, stress, and to evaluate whether before and after intervention the person is actually better off. And this framework that we've used within the Northern Trust has now informed, with input from many others across the region and service users and families and carers, the framework that has been developed as part of the Regional Mental Health Service and the strategy to enable us to bring forward a consistent approach to that data moving forward. Obviously other trusts have similar approaches, but clearly the approach is for Northern Ireland for us to have one clear and consistent set of data that enables us to answer the question about are people better off as a result of the intervention they've received.
Okay, thank you. My colleague Dan Forsyth will pick up on that shortly and would reflect back on that, but I do appreciate that at this point. Over the last number of weeks, you've seen, I'm sure you've been following the business of the Assembly. There's been much discussed and much has been indicated as a priority for various departments and indeed Assembly members. In fact, everything is a priority if you really look at it in a certain way. But what has actually been done to ensure that mental health services are prioritised in the interests of people across Northern Ireland?
So we've used the mental health strategy as our North Star, as it were, the guiding light. It was a 10-year strategy agreed in 2021. It wasn't only something that the then Minister of Health put in place, but it was something that was agreed by the Executive as a whole. Indeed, there was a commitment at that time by the Executive to the funding needed for the mental health strategy, and we still hope that that will be possible. So far, that strategy sets out 35 actions. Delivery has started on 20 of those. As I mentioned in my opening remarks, a number of key areas have been advanced, including those community perinatal mental health service, where I understand it's 75 individuals each month who benefit from the experience that is possible now compared to what was there before. The plan for the establishment of a regional mental health service, and I might ask Peter just to say something more about that, the establishment of a digital mental health board and the rollout, as I mentioned, of emotional health and wellbeing teams in schools. But do you want to say something about that regional mental health service, Peter? And we just recently appointed a lead for that.
Thanks, Peter. Yes, the Regional Mental Health Service is one of the, I suppose, flagship programs of work that we want to take forward in mental health services. It's one of the ones that of the standout actions in the strategy that the Minister highlighted when the strategy was published. That's a way of bringing a regional consistency to mental health services across all trusts. It's not about building a new organisation, but it's about making sure what we have and what we are currently delivering is done in the best way possible, using our people to the best way possible to make sure everyone has equitable access to services no matter where you live. So, and again, as well as being a standout action, it was an enabling action in the strategy because so many different actions of the strategy fall off that. So we've put a lot of effort into making sure we know what that service looks like. So we now have a 5-year implementation plan to turn the concept into reality, and to lead on that delivery, we've recently appointed a head of the Regional Mental Health Service who's going to take that piece of work forward and bring that into reality. In the first instance, that means establishing what we're going to call a collaborative board, which will be not just trusts, but it'll be people from the community and voluntary sector, people with lived experience, trusts and other departments, because of the collective nature that we need to address mental health services. That's how we get prominence, that's how we get visibility, that's how we know and we demonstrate.
I appreciate the merits of the strategy. I've seen it, I've read it, I've listened to an evidence session last week in relation to it. That's the strategy. It was 2021, we're now in 2024. What has been done to show the public that this has been prioritised? Because from what I hear at the minute is health waiting lists are a priority. Yes, they are. Mental health services are a priority. Is this a priority, and what is the department actually doing to ensure that that is the case? I don't want to hear about the merits of the strategy. I know what needs to be implemented. I want to know what has been done since 2021, when this was very well put on record that there was a very serious issue in mental health services. And what I'm hearing at the minute, and hopefully I'm wrong and you're going to correct me, is that very little has happened, only that you're reflecting on a strategy that isn't yet implemented. What small changes, if any changes at all, have been implemented to improve this service, to show that it is a priority for this department?
Well, let me repeat some of the things that I said in my opening statement, Chair. So we've implemented a community perinatal mental health service across the region with teams in place in all 5 trusts. We've completed a 3-year early intervention and prevention action plan with progress made on the implementation of actions. We've completed and published an independent mental health workforce review with work underway to begin planning implementation of the key recommendations. We've made an additional investment of £2 million in the child and adolescent mental health services to enhance existing provision and alleviate pressures, particularly within inpatient settings. We've rolled out the emotional health and wellbeing teams in schools with initial cohorts of schools identified and engaged. We've established a digital mental health board and appointed project leads to develop a digital mental health service action plan. And we've completed a review exploring the optimal approach to engaging the community and voluntary sector in the development of mental health policy and provision. But let me also say, in answer directly to your question, that the strategy had envisaged and set out a costed year-on-year framework over the 10 years as to how that would go. And there is a harsh reality here that the department has not been able to fund the strategy at the levels that the strategy envisaged when it was published. That is not a signal of a lack of priority within the department. It is actually a signal of the very serious financial challenges that the department has been facing, certainly in the 2 years that I've been in post. And as I've said, they look likely to worsen next year, with concerns about our ability to continue to deliver current services, let alone starting to invest in new ones. So we've invested around £9 million in the strategy to date. We would like to do more. As I said, we'll be in violent agreement on the need to do more and the importance of it. And I know, having heard the Minister of Health talk on a number of occasions, publicly and privately, that the mental health strategy is one of his key initiatives as well.
I appreciate your answer in relation to my questions, Permanent Secretary, but I still don't appreciate that you're getting the question that I'm asking. There's a number of priorities for your department, as there is for every department. Multiple departments have very fancy, glossy strategies in place, as does this one in relation to mental health services, and a load of others. I could list a mountain of them. So what has been done I'm being told this is a priority. We've launched an inquiry into this area for that exact reason. Services are collapsing, in fact non-existent. There's no data to give an accurate reflection of where things are. What is your department? I still am not hearing. I'm hearing that there's no money, that there's a restriction on the budget. We know that. This is not a new problem. The mental health challenges that we're in today is not a new problem, but they have worsened. And I'm asking, if you're saying this is a priority, how do you deal with the competing priorities of your department to ensure that this is actually prioritised to ensure that services are protected for those most in need?
Well, what we've done each year is to look at, within the budget available, how much money we can invest in the mental health strategy. We've, as I explained, engaged with partners and others interested and involved in the mental health space to ensure that it's not just our priorities, but it's their priorities as well. We've made the investments that I have described, and we've done so in a context where, in both of the last 2 years, we were on we had such a budgetary challenge that we were projecting an overspend until there was an agreement reached with the UK government that resolved that issue, which meant that, as accounting officer, my responsibility was to secure break-even, and that limited the amount of investment that could be made. So, of course, there are lots of competing priorities, and we work through each year in a budget process with our trusts and other arm's length bodies, and our minister ultimately, when ministers are in post, as they thankfully are at the moment, set the priorities and determine the budgets for the different areas. So that's the process that we follow in order to achieve this.
Just with that in mind then, and I'll move on to other members shortly, if that is indeed the case, is the current strategy with 35 recommendations, is that correct?
35 actions, yeah.
35 recommendations. Is it realistic and achievable given what you've just said?
So, as I said, it remains our North Star, it remains the direction of travel, and we will go down that direction of travel as quickly as the budget allows. Clearly, we have not been making the speed of progress that the strategy envisaged. And as I've said, this year it looks unlikely that we're going to be able to accelerate that. So it becomes less likely that we'll be able to achieve it in the time frame that is set out, as in the 10-year time frame. But for the reasons that you and doubtless many other members here will draw out, there is a real and urgent need for us to be able to make these changes. And we would all like to be able to invest in this area, and there are other areas we would like to be able to invest in as well. This isn't the only area where there are challenges. You did make some comments about data and so on, and I'd like to come back to those perhaps in response to some of the detailed questioning, because I didn't accept the formulation that you used around there not being any data. I think that's inaccurate, and I'd like to have the chance to explain that in more detail, but I'll wait until we get into the detailed questions in that area.
We will, certainly will. The data is not reflective of the reality, is the point I'm making, but I thank you for your response. John Stewart has indicated briefly, and then we're going to...
Yeah, thanks, Chair, and you did cover a couple of points I was going to make here. Permanent Secretary, thanks for coming tonight. Just on the budgetary picture that you painted there, I'm just keen to get a flavour for... There's been a lot of talk about the impact on health as a result of the tightening financial situation here in Northern Ireland. What is your initial assessment of the impact of that? And is there a chance, given what you've said, that we could end up spending less in 24-5 on mental health and the strategy than we did in 23-24?
So we're not at the position where we're able to reach a judgment about exactly what spending will be this year compared to last year on the mental health strategy. There's detailed work to be gone through for that. But the draft budget numbers that I have seen would cause very substantial damage to health and social care services in a range of areas, and it will be incredibly difficult to break even with that budget.
Right, thank you, Chair.
Thank you, Permanent Secretary. Cahill Boylan, MLA.
Thank you, Chair. And you're very welcome. Thanks very much for the answer so far. Just the committee was struck by the sheer size of the mental health fund, to be honest, with a 35 action plan and the 1.2 billion costing. And it is a priority, and I'm glad, Peter, you refocused on that. My first question is, did the department focus too much on developing the strategy as against the expense of the actual delivery of the strategy itself, in your opinion?
I don't think so myself. I think that one of the good things about the development of the strategy is that it came with a fully costed plan over the 10 years and a clear eye to implementation. It was being developed and Peter Toogood can say a little more about it, having been very closely involved, but it was developed during the COVID years, and there probably was a different financial horizon at that time. It wasn't clear that we would end up in this very severe budgetary challenge that we have done in the last 2 years, and as it looks like for this year coming, and that has changed the speed at which we're able to make progress. But our commitment and our focus on taking forward these actions and doing sensible work, either preparatory work or actually substantively meeting the commitments, remains strong. I don't know if you want to say anything more about it.
Just before you go, because you said you believe so. So my next question in relation just to what you said, so you're saying then it's deliverable? Because you believe in the strategy. So I'm asking you, is the strategy deliverable over the period?
Well, I've kind of answered that question already to the Chair, I think. I've indicated that we haven't been able to make the speed of progress that had been envisaged in 2021, and that if this budgetary challenge continues, then it's going to be extremely difficult to deliver all of the strategy within a 10-year time frame.
Yeah, very.
Thanks. So you're right. I mean, in terms of the balance between development and implementation, you're absolutely right. We have been conscious of not getting that out of kilter. So in developing the strategy, which is, as Peter said, took place at a very difficult time for society, we engaged with over 300 people in developing the strategy across a whole spectrum of users, people with lived experience, etc. In shaping the strategy, when we put it out to public consultation, there were 400 responses, all responded largely positively to what was there. So we took time to do that over a 12-month period, which we felt was right, to make sure that we got it right, so that we were starting on the right footing, I suppose, so that, it's ambitious, you're right, 35 actions, but we wanted to make sure those were the right 35 actions. So since development, so that when the strategy was published in June 2021, I suppose implementation has been shaped by primarily, as we've heard already, the financial context that we've been working in. We have had single-year budgets since then, which has, I suppose, prohibited how far forward we can go. So what we've done, I suppose, to match that is publish annual delivery plans, because for me, it's looking after this work, it's important that we don't look and say it's all too difficult, so we're not going to do anything. So those delivery plans, we try to focus on what could be delivered with the limited resources that we had. The Minister was always clear when he published the funding plan that additional resource would be needed, and that was not forthcoming with the budget at the time. So we did make a case and got the additional funding released from within the department. And as I said, over those 2 years and those 2 delivery plans, we've really tried to focus on stuff that we can do. A lot of it's proprietary work, I accept that, but it's important proprietary work. So like the workforce review, like the outcomes framework, really, really important stuff to make sure that whenever we do make the big changes, that we're doing it from a sound footing. I think it's fair to say the real game changer will be when we do get the additional funding as highlighted in that delivery or the funding plan, because the majority of that funding will go on staffing and workforce. That's where the real service change, the real material change we will start to feel. But I think at the moment we've gone about it pragmatically, I think sensibly, to make sure we're ready and that we're on a sound footing, I suppose. So I think the balance at this stage, we've got it right between the development and what we've done on implementation.
Okay. Second point is, and you can correct me, you've said you've spent 9 million to date, and you've outlined a number of key actions, and you've said them twice, to be fair, just follow on from the Chair's points. So have you done a measure of that, of where you're at now in terms of what you've in the first 3 years? Is there a measure of that? Can you say where you're at? Because you keep talking about funding, which is grand.
Yes.
It's going to be probably the subject of many questions. But where is that in terms of the measure now, as was said?
As I said, we've commenced 20 of the 35 actions. We published the annual delivery plan that Peter described, and Peter, can you say something about the extent to which that covers progress that has been made in the year previous as well?
As I said, there's only been 2 plans. We're developing the 3rd one at the moment. So in the first year, we set out what we were going to do, which is the first plan following the strategy, which is 22-23. In the 23-24 plan, we said this is what we're going to do, and this is how we've done going forward, because this is what we did going backwards, and how far we got in year 1, and we used that to help inform what our priorities should be in year 2. And we're doing the same at the moment, that we're going through that process of what have we done and what do we need to focus on year 2. So I think it's fair to say that first of all, we're not doing that in isolation, just the department. We are doing it with everybody who's involved in designing the strategy and delivering it. So it goes beyond ourselves and the department and the trusts. But I think from what we've done to date and what we need to look forward, I'm happy to say what our broad priorities are shaping up, because that's reflecting the learning that we've had, if that's helpful. Or...
Well, Chair, just as follows in my next question, I've only 2 wild points. The question would be, in the absence of funding, how are you prioritising the strategy? And also, what are you not going to be doing then? Can you expand a wee bit on that?
So, I think you're almost taking you on to where you were, but one of the key areas that will be very difficult to advance is to do more on workforce, because in order to train people, you need additional funding to be able to recruit more people into the service. You need more posts. So that will be one of the key constraints. And I guess it may be a theme, going back to what the Chair said as well as what you're saying, that until we're able to grow the workforce significantly, then people won't feel that there is a difference on the ground. And because the level and scale of the challenge is still actually getting bigger rather than getting smaller. But do you want to say something about how we set priorities within the strategy?
Yeah, and again, I suppose it's looking at those actions that are necessary and essential upon which to build on. Picking up Peter's point, even though our ability to invest heavily in additional workforce is going to be constrained, our priorities for next year have that theme of workforce at the forefront of our minds, because that has to be at the forefront if we're going to change anything. So there's probably 3 key areas that we're going to look at next year, mindful of the workforce challenges. First one is the regional mental health service that I talked about. That's about using what we have in the best way possible and providing the basis upon which to layer in the additionality. The second priority is around the community and voluntary sector. We want to focus on that because that is a huge workforce in the mental health services. We're conscious that is an area that we need to be better at interacting together with. We need to understand better what's there, what they can deliver, and make sure that that sector plays a huge role in the delivery of services. And then the third area is the whole issue of psychological therapies. That runs through the strategy, it runs through our workforce review, and it's one area that is evidentially proved to make really positive outcomes on people. But again, we need to do work around, well, what does the psychological therapies workforce looks like? And that we have some, I suppose, options on the table that we're going to enact, and Peter may say something about those shortly. But that's where our mind's at. We learn from the past. We are mindful of what's going on in the external environment, and we shape our priorities accordingly. But that gives you a sense of where we're going next year.
Would you mind if Brenda just wants to add something, if that's okay?
Chair, if I might just give some additional information which might help Carol Boyle in terms of the question about how we have prioritised over the course of the last year. So by way of example, the single biggest area that we put financial investment in last year was our children and adolescent mental health service. So it got £1.9 million went into it. Our next most significant area of expenditure was our perinatal mental health service. So, and again, Permanent Secretary referred to that in his introductory remarks. There was also £1 million which went into early intervention and prevention. Coming down in terms of the next highest level of expenditure would be our regional crisis service. So you can see there the funding that has been available has been invested in early intervention, in children and in crisis support, and in perinatal have been the areas that were prioritised. And that was as a consequence of the areas that were prioritised in the one-year delivery plan, which was done in conjunction with people with lived experience, their carers, and those who are working within the service. Hopefully that gives some help.
I'm careful not to delve into any other areas. Just quickly, in terms of, is there a review built in? And also, can you say how much has been bid in the 24-25? What's been bid for mental health?
We kind of use the annual delivery plans as a means of review. I think it's fair to say I'm not sure that there's a distinct review that's built into the programme. And in terms of 24-25, we'd be looking to maintain the funding in the areas that we've identified. And then there are a couple of areas where we've made bids, but I'm not expecting necessarily they're going to be met. One of those is a workforce to indicate in relation to transformation how workforce could be expanded, and not just in the case of mental health, but mental health would be a part of that. And then also looking at multidisciplinary teams within primary care, where mental health play a core part, along with social workers and physios and others, where again it would be our aspiration using the transformation funding, and that funding has not yet been addressed, so I shouldn't say I don't know how that will work out. But the MDTs is another area where we've looked for additional funding.
Okay, thank you. On Gilderney, MLA.
Yep. Thank you. And thank you for your attendance here and for the answers you've given so far. And I suppose just to very, very briefly set the context for when it came up in front of the committee here about which of the various areas of concern we were looking to focus on, I had said that this was one of them that I seen as very key, and seeing constituents with significant difficulties. And just to give you an example, Permanent Secretary, and I can send you the email, I have removed names here to protect confidentiality, but I have an email back recently from one of the trusts. In relation to your inquiry on behalf of your constituent, I can confirm our service manager for the community mental health team has confirmed that a referral was received by the team in March 2022. Regrettably, the current waiting time from the date the referral was received is approximately 5 years, and your constituent remains on the waiting list. And just in the context of mental health, I mean, 5 years is, you know, it's questionable whether it's going to be of any benefit to that person, you know, given that scale of time. So that's the real human impact of what we're dealing with. Now, I want to focus a wee bit on the workforce issues, and there is a truism within health, and we have, I have to say, and we are blessed to have one of the probably the best, most dedicated and devoted workforces anywhere in the world. They are working under impossible pressures at this stage. They're trying to cover gaps in staffing. It's not even at times even safe staffing levels, and they're working away out there on the coal face. And I'm going to go into the vacancies. But capacity and proper staffing has been highlighted as a major concern, and about 10% of the posts currently vacant. And I have seen the review. I'll come to the review in a minute. We don't have enough clearly mental health professionals, as has been touched upon, to support service delivery. Just in a short answer format, how vital is it that we fill these vacancies?
Well, as I referenced in relation to an earlier question, I don't see how we're going to address the problems with meeting the breaches in our waiting times if we aren't able to invest additionally in workforce. There's only so far that we can stretch productivity, and so there's a harsh reality here that if we don't have the funding to invest, then it's going to be very hard to see how we turn the curve in this area.
Okay. So the mental health champion who was in with us helpfully last week has told us that for her, building the mental health workforce should be and needs to be the #1 priority going forward, to increase the level of services provided and increase access to those services. As I said, I've seen the workforce review, and the department has undertaken and identifies the need for 2,000 extra staff over the next 10 years. So my first question is this achievable or even realistic, Permanent Secretary, given the current recruitment and retention issues within the health service?
We're currently on a one-year budget for 2024-25, and there are not, within the budget that I'm expecting that the department will receive, it will be very difficult to make significant progress on workforce in terms of the overall expanding the quantum significantly. There are, we continue to look at all sorts of innovative ways in which we can bring people into the workforce. It's not purely through the training route. There are other avenues that we can use. Peter Toogood has explained that workforce will be the key theme for next year, but the budget is going to be a major constraint. I hope that we will move, I have said this for over 10 years, I hope that we will move to multi-year budgets, because there's no way to run a health service or any public service to be working on one-year basis. And I hope that will be possible very soon. And that will then allow us to set a longer term frame and actually to be able to answer your question more fully than I am able to today.
So do you feel yourself that the department is acting urgently enough in order to get the staff that's needed in place?
It's my belief that the department is doing all it can to implement the strategy in highly constrained circumstances. And I don't wish to distract, but there are multiple areas where health and social care is facing very significant pressures. And it's not possible just to look at one area, however big a priority it is, without also looking at the consequences right across the whole of health and social care. And I suspect, and I won't do it because I think it's not fair on MLAs, but it's very hard to understand where to take the money out of in order to put extra money into mental health, which is essentially the question that's the only way that we could answer that. If we wish to put more money, there's no additional money coming centrally. The only way we can do it is by taking money out of a line somewhere else and putting it into mental health. And that's a very difficult thing to do when you'll know from your time as chair of the health committee the very severe pressure under pretty much all aspects of health and social care at the moment, including workforce pressures right across the board.
And I do, Permanent Secretary, recognise the benefit that a multi-year budget would bring. However, traditionally it has always been a certain trajectory, and there are certain things that you can kind of almost anticipate that you're likely. I don't think there's been a cut in health for a significant period of time, despite the challenges financially. But there's a long tail to staffing issues as well. So urgent action and quick action now is needed to even address the situation in 2, 3, 4, 5 years, up to 7 years, depending on the health professionals. So in that context, how many additional training places has your department commissioned since the strategy was published?
I have some data here I can tell you for the clinical psychology doctorate at Queen's, there were 11 places in 2018-19, and there were 21 last year in 2023-24. My understanding is I've seen a number of 23 somewhere as well, so I don't know whether that's the plan for next year. In relation to mental health nurses, there's been more of a fluctuation over years because for a number of years there was extra funding available that allowed us to increase the number of nursing places overall. So in 2019-20 there were 130 places, and that increased and hit a high point of 195. We're projecting at the moment 165 places for mental health nursing in 24-25. So that's the answer to your direct answer to your question in relation to some training places.
Would those figures put us on a trajectory to solve the problem?
Not in themselves, no, and for all of the reasons that I've explained.
Okay. Okay, thank you.
Just a number of points to pick up from what Colin said, and then we'll go to David. But you obviously can't train specialist mental health staff quickly. So, what capacity is there currently within the system to train the number of staff that you need? Do you need to increase that particular training capacity? And have you drawn up plans to achieve this? How long will it take if that has indeed happened? And a further point that I'm hearing more and more since the return of this assembly is the loss of specialist staff to other jurisdictions. Is that the reality for your department in this particular area?
So on the second one, I don't have an evidence base that would support that. There is certainly not specifically to mental health. The question could you just remind me of your first question? Apologies.
In relation to training, so in relation to specialist training for mental health staff, is there the capacity within the system to meet the demands that are there by ensuring the staff are appropriately trained?
So as I said, this is an area, like many areas, where we would like to make an additional investment, both in medical and nursing staff, and that would also be true for social workers and allied health professionals and many other specialties for doctors and nursing. I mentioned that there were other routes, so the classical route is the doctorate in clinical psychology, but there are also other training routes that graduate psychologists can consider. One is a CBT diploma, the second is a psychological wellbeing practitioner, the third is a clinical associate psychologist, and the fourth is a PG cert, a foundation in applied psychology. So those are all alternative routes which can help us to increase our workforce in the short term, enable us more quickly than the doctorate does to bring people into the workforce. And we're exploring all of those options as to how we can best do that. But understandably, some people would prefer to go down the classical doctorate route. So that's a challenge. And I don't know, did you want to come in?
So just the point I would make, just in terms of access and services. So, and this will be touched on more widely as we go ahead. But if someone presents today with a mental health issue, they're sent or referred to a very busy A&E. So if we take Alt McGalvin as an example, that person may wait for a period in some instances of up to 2 days before they're properly seen, and are sitting on a seat and maybe in a very vulnerable state. The staff that I've spoken to in A&E departments are telling me that they're not trained to cope with the challenges, the complex challenges of those with severe mental health issues. Yet they're put into A&E, and I'm told it's the best place for them to be sent to. So what's your view in relation to that? Staff currently within A&E that are dealing with this at the coalface are telling me, and others I'm sure, that they are not properly trained to be dealing with someone with severe mental health issues.
So there's a few points that I might make, but some of my colleagues who are closer to the detail may also want to add to it. There are a number of ways in which people can access mental health services. The reason that the emergency department is one of them is that it's a place of safety under the mental health order, and that's a reason why some people end up in emergency departments. But there are means through both primary care, GP out of hours, and through the crisis service where people can access mental health without going to mental health services on a crisis basis without going to an emergency department. I don't know, Brenda, do you want to add to that?
Yeah, no, happy to pick that up, Chair. So there, as Permanent Secretary says, there are some people for whom emergency departments as a place of safety and in need of medical assessment is the right place for them, but for many people it isn't. Now, there are a range of alternatives that are currently there. They're not universal across every trust area, and that's why crisis support services will be part of the prioritisation of the mental health strategy going forward. But there are other arrangements other than EDs in place. So by way of example, there are some of the things that Assembly members will be well aware of. The regional telephone support services, Lifeline, Samaritans, Childline. There are places within the community where people can access support, for example, crisis cafes. There are support through primary care GPs with the mental health practitioners in the primary care teams. There's also the multi-agency triage team, which is the team working alongside police and ambulance services to support individuals who present to those services so they can redirect them away from ED and get them appropriate help when needed. Within hospitals, there are mental health liaison services, and each of the trusts have crisis response and home treatment teams. So I accept the point in terms of...
There's a number of points to this.
Yeah.
Mr. Toogood told this committee a few moments ago that the department, particularly in relation to mental health services, are aware of what's going on in the external environment. What I've just heard tells me that that is not the case, because many people listening today would argue very strongly that A&E, particularly if I'm going to reference Altnagelvin Hospital, is not a place of safety for vulnerable people. It is not a place of safety, and it's not a place of safety not just for the vulnerable people that are going through the door, but for staff that are working in that chaotic environment. And to suggest that GPs can see people with mental health issues, the waiting list to see a GP is significant. You cannot see a GP if you present today with a mental health issue. You cannot see the community mental health team if you're not known to them, already register them with a pre-registered illness. The reality is that accessing the service is non-existent, only via A&D, and it is not a safe environment. So I find that deeply troubling, to be honest, Mr. May, Permanent Secretary, that the department consider, and I would do well actually for senior officials within the department to sit in an A&E at a weekend to see how safe it is. Because I can tell you, the manager of the A&E in Derry, the former one, and many other staff have told me that it is not a place of safety for vulnerable people.
I think there may be a risk of a misunderstanding here. A place of safety under the mental health order is a specific legal issue. Nobody believes that it is desirable for people to spend long periods of time in emergency departments. I know that in the context of Altnagelvin, they've been doing a lot of work in order to try to reduce and minimise the number of occasions on which that happens, and try and eliminate the number of times on which that happens.
Mr. May, is the ED in Altnagelvin, just an example, is it a safe place? This is an important, because I think recent headlines, even beyond the point of those with mental health illness, have pointed that that's not indeed the case. That we all know, and that's one example of many, it's one that I'm very, very aware of, it is not a safe place for people with vulnerabilities, let alone those with illness. It is not. And many, even those senior within the trust would argue that it's not a safe place. It's not fit for purpose, in fact.
I think we would all acknowledge that it's an undesirable place for people with mental health problems to remain. The purpose of our service is to maximise the safety. The reality is that those with very severe mental health illnesses always have risks to safety, and we have to try to manage and mitigate those as best we can. I don't know, Dr. Kaur, would you like to say something? Because obviously you manage these services within a trusted environment, about how that safety is managed in the context of, for example, someone presenting at an emergency department.
There's very significant complexity in all that you're talking about, Chair, and I think we appreciate that. I think if we attempt to think about crisis attendances in relation to mental health and routine attendances in relation to mental health as two separate issues, and I think it's important for us to make sure that we address both of those, because actually it's really important that both parts of that really important part of the spectrum are addressed. So we've talked a little bit about crisis, and I'm happy to pick up on the questions that you mention. Clearly, as Peter has mentioned, the mental health order has a legislative clause within it that allows for certain areas to be specified as a place of safety for an assessment to be carried out and for a person to be held pending an assessment. And an ED is definitionally one of those areas. The issues around the complexity of EDs largely are to do with general busyness of EDs, and we all know about the pressures across our ED system, and also to do with the prolonged nature of waits on occasions. And that issue is really to do with bed occupancy if an individual requires to be admitted. So if a person arrives in a position of distress and is very unwell, within our EDs and within our hospitals, we have mental health liaison services who are professional and senior qualified practitioners with mental health experience who work within the hospital system and who will see people within the 2-hour period, who'll complete an assessment, who'll devise a care plan, who may prescribe medication, who will support individuals who are there. There's a range of provision across Northern Ireland in relation to that. Not all have 9-to-5 services. Not all have 24/7 services. Some of the trusts have 9-to-5 services across, and they're subsequently supported through crisis response services thereafter. So the support is there through many of our EDs and is always available. The issue in particular that you raise around the prolonged waits is because actually of a problem in a different part of the system, and that's to do with acute bed pressures. So if a person is detained, so if we imagine that the person in mental health liaison sees the individual, completes an assessment and feels that that individual actually requires a detention under the mental health order or an admission to hospital, at that point then there's a process that's gone through with the GP and the ASW, who's a senior practitioner who makes those determinations under the legislation, and the process arranges the conveyance of that person to hospital. The complexity in Northern Ireland is that we find ourselves in a position of over-occupancy across our hospitals. So on many days we don't have a bed available, and there's a significant amount of work needs to be done to create bed stock to enable a person to be admitted. So that may mean that the individual there needs to be an assessment about where the individual who's at that point in time in the ED, where they most safely remain while awaiting the bed to be facilitated and that person to be conveyed. And that's really the issue. So there's certainly an issue around the ED being a busy and challenging environment. It's important though for people to go to an ED. I mean, I think it's an important message just for us to make sure that people know that they can go to an ED, and they may need their physical health checked. For if you imagine someone has potentially cut themselves, they've maybe overdosed, they've maybe attempted to hang themselves, and there could be an issue that does need physically checked as well as their mental health checked. So it's important that we don't inadvertently message the wrong message.
I appreciate that, but it is not in line with reality, because mental health trusts across Northern Ireland put out on busy days do not come to the A&E unless it's an emergency. Often those at a crisis point do not believe that they are an emergency and do not want to sit in a busy ED department. That's feedback that each of us have had from constituents. You've used the term, Permanent Secretary, legally safe. Is it clinically safe, is the question.
Look, I'm not a clinician, so I'm not equipped to make that judgment, but I've indicated, having spoken to clinicians, that the service makes every effort to mitigate and manage safety issues. You can't eliminate safety issues when there are severe mental health illnesses, whether that be in an emergency department or indeed in any other setting.
So briefly, and then I'll move on, to give you an example of an experience in ED. There's people sitting in ED that go in because they can't see their GP and can't get access to the Q&A mental health team, whether they're known to them or not. They present to ED and may sit there for a period exceeding 24 hours to 2 days, depending, as Dr. Corr rightly points out, the availability of beds. We're aware of the challenges in that, and I appreciate how severe those challenges are. But they're sitting in an ED that is surrounded and very busy. The staff are overworked, exhausted, and dealing with multiple patients with multiple issues. Those vulnerable people in a very poor state of mental health are sitting on a seat for hours, if not a couple of days. I am aware of occasions, and I've raised it, where that vulnerable individual has left the ED department, and it has been some time before it was noticed. That is not a clinically safe environment for a vulnerable person. I'm sure you'd agree.
I'd be happy to respond to any individual case you'd like to raise with me specifically.
The point I'm making, and I think this is a key starting point for accessibility to services, is that the emergency department is not the most appropriate place unless there's a physical injury for those vulnerable people.
And I think the doctor was explaining that I think that we risk sending the wrong message out because emergency departments are designated as a place of safety for a reason, and it's really important that we don't go down the wrong path here.
That may be the case in writing, but it's not the case in reality. And I really need the department to understand that emergency departments are buckling under severe pressure, and sending vulnerable people to those departments in their current form without addressing the concerns of trusts across Northern Ireland is making an issue much worse.
So I accept. Let me say that I accept that our emergency departments are under severe pressure. I've highlighted in answer to other MLA's questions the severe pressures there are on all parts of our system and the very significant risks there are going forward. And no one is minimising those risks, or we would all want to be able to take many more actions to try to mitigate those risks than we're currently in a position to do. So I don't think, as I said at the beginning, I think we're in violent agreement about the way in which we need to try to develop and move this service forward. The key inhibitor here is the means with which to achieve that. And it's a source of great frustration, huge frustration to those who work in emergency departments, but also to those who manage and trust, to those of us in the department, that we currently are constrained in that way, and it is very difficult to make the change that is needed.
Chair, if I could just come in to offer a level of reassurance on behalf of my director colleague from the Western Trust. I'm very conscious that she is in the midst, in collaboration with colleagues from the ED, on a specific improvement project around the identification of a separate and safe space for individuals while they're waiting. So we receive feedback from MLAs such as yourselves, from our service users and our families, and we do work to do what we can to create more appropriate environments. And it's important just to acknowledge that work is ongoing and that improvement project's underway, and hopefully that will make the situation better for those individuals during that period of waiting.
Thank you, Dr. Corr. I have a very good relationship with the Western Trust, and I'm very aware of the good work that they do, but I'm also aware of their concerns in relation to the emergency department that needs to be addressed by the Department for Health. We'll move on. David?
Thank you, and thanks for being with us. I want to look at funding and why we don't have the funding being spent in mental health. But before I do, you pricked my interest, and I wanted to come in on a supplementary to Cahill. Peter, you said about the voluntary services and using that area, and organisations using that area and getting better at that, and we have some fabulous voluntary sector services in all of our constituencies who do fabulous work. I'm just concerned at that. Who funds that? Are you expecting a voluntary service to deliver services for you effectively and also fundraise to keep themselves alive at the same time? Is that what you suggest is the way forward?
So, I think one of the strengths of the development of the mental health strategy was that it did engage widely, including the community and voluntary sector. That is a very varied sector, as you know, with organisations that are large in scale and deliver services, but also a lot of voluntary services that are done purely on a volunteer basis and aren't necessarily looking for funding. And I think in number terms, there are more of those services than there are the big deliverers of community services. So I think it can be quite hard when you try and bundle everything into the one box. You end up potentially ending up looking at things through the wrong lens. But clearly, if we commission a service which involves the community and voluntary sector, then that will be on the basis usually of some form of competitive process by which we end up agreeing what the appropriate cost for that service would be. I don't know, Peter, whether I think it was David was picking up on a particular point that you'd made about the use of the community voluntary service sector. Did you want to add to it?
Yeah. I mean, we engage at the moment, as Peter has outlined, I think in a way, I'll be honest, a suboptimal way with the sector, because it's very much along the lines of we want a service and we go through a procurement and that provider-supplier relationship. On a related piece of work on children's services, social care, there's a recommendation around changing the dynamic of the relationship between ourselves and the community and voluntary sector. That theme runs through to mental health services. It runs through to how we engage in its broadest sense, because I suppose our desire in the department is to change that dynamic so that it's not that, this is what we want, you will provide and we will hold you to account. We still need to do that, but we need to do it more in a co-joined way. We need the community and voluntary sector to plan, develop and deliver services. I think we're getting better at the developing bit. They've been involved in all this. We need to do more in the planning and the delivering, because we do commission a lot of work from them, and we wouldn't be able to deliver our mental health services without the sector. So to me, that's why, as I mentioned earlier, it's a big priority for us next year to really make that better. We're not there yet. We know we're not, but there's an absolute desire to be that.
Security of funding there that they need at the other side of that, but leave that for a second. Figure 6 of the audit office report clearly indicates that significant lower levels of funding on mental health here. When you compare that to other jurisdictions in England, for example, it's nearly 3 times what they spend of their health budget in mental health. Why can we not do the same?
I think that we started from a low base, and through the strategy we aspire to being able to increase the level of per capita spend. I think that the most recent figures that the per capita budget is, I think a few years ago, the most recent figure I have is for just over I think it's £200 per capita, and the proportion spent on mental health services is 7%, is my understanding now, whereas that's accurate in 2019-20. So we've made some progress, but obviously we've a long way to go. I think the mental health strategy sets an aspiration or a target of 10% in terms of the proportion of the health budget that's spent on mental health services. Is that correct?
I think it's the CAMHS percentage of the total.
Okay, apologies, I got the wrong percentages.
Yeah.
Okay, so you said earlier about taking the money out of somewhere else and putting it into, what was the choice of that, of taking money out and putting it into mental health, but the finance costs associated the implementation of the health strategy aren't available within the departmental resources, but yet they are in England, and we spend more on health per capita here than they do in England. So if we're spending more here and they're spending less in England, and there's a 10% difference, and that roughly is around 600 million. I don't understand why the budget isn't available. So I can't get my head around that, yet it is available in GB and it's not available here, and we have to take it out of something else. So what are you overspending on? Or what has been overspent on that can then be moved or be spent on mental health?
Yeah, I think, something like the Fiscal Council report sort of covers this in some detail, and I think one of the key areas of analysis is what are the comparative levels of need here compared to England, and I think it's widely accepted by pretty much all commentators that Northern Ireland has higher levels of need than is the case elsewhere. So, as I said, we've got we started from a certain position. We are looking to change that position as we go forward. We are always looking at how we can make efficiencies and savings, and I and the department have launched a number of different pieces of work designed to look at how we spend our money and whether there are areas where we ought to be looking to reallocate money into different areas, but that work hasn't yet concluded. And my experience so far in the 2 years that I've been in the department is that there's often a lot of complexity around the reasons for spend, which can be difficult to unpick, as it were. So we're always looking at that, but I would suggest that any MLA here will find it difficult to say, well, that's the bit of money that's being wasted and needs to be taken away and put into mental health.
We're not the experts to look at the budget, so I'm not.
I suppose what I'm saying is that with the expertise that we have at the moment, I have not yet identified either where that.
Well, if I look at a report from Newfield and it says there's 410 million been spent in hospitals because we're keeping people people staying in hospital too long because we don't have other services. There's 410 million of your 600. If that's addressed, that's what I'm saying. Where are we overspending that we're not spending? That's a Newfield report.
Obviously, to address that, it's primarily about investing in social care in order that there is somewhere for those people who are in hospital to go and to be safely cared for. That's the reason that they're kept in hospital for longer. So you can't just take that cost and assume that money wouldn't, because there's money that would need to be spent in social care, and it's right that we have made an investment this year in social care, both to bring the national living wage into place, but also to go beyond that to try to encourage more people to join the social care workforce. That is a key constraint at the moment for us, and one of the reasons why we have lengths of stay that are longer than we would like.
Is it just simply there's a lack of transformation that we're not getting on with it? Is that a part of this?
There's always a need to do more in terms of transformation, but we have actually delivered a lot already. So you'll be aware, and this is moving away from mental health specifically, because obviously we've talked about the things that we've done in mental health services under the strategy. But the move to try to separate the elective space from the urgent and emergency space through the creation of the elective overnight centres in the Southwest Acute, in Daisy Hill, in the Mater, the introduction of day procedure centres in Lagan Valley and Omagh, the introduction of rapid diagnostic centres in White Abbey and South Tyrone are all examples of transformation where we're beginning to, we're simplifying the pathways. We are making it less likely that individuals will not get their procedure because of an urgent and emergency pressure at the same time. So those are examples. We've also, in the last year, moved a number of services, including general surgery moving in a couple of locations, maternity services moving from Causeway to Antrim, and so on. So there are indications where transformation is happening. But yes, there is more to do on transformation. I think your question, though, is indicating a supposition that if we transform, health will become cheaper. And I think what we have to recognise at the moment is that we have very high levels of unmet need. We're talking about one aspect of that today in mental health. So the first thing we would do with transformation is to try and meet that unmet need, and it won't actually save money in the short term. So just to be clear that there's no direct magic button here that you transform something and there's lots of money that comes back. No, but I'm just being
I'm just suggesting that you asked us a question and I said I can read reports, and I read a report to say there's 410 million of a saving that they're not spending in England. But whenever if you look at the PAC Part 3 of it, the overall funding levels have increased in the last decade, but the mental health share of the overall and social care budget's actually reduced over the last while. Now, given the significant impact on mental health on individuals and wider society, by reducing the overall budget, I would suggest that reduces the early intervention that Daniel was talking about earlier, and that interface and treating people quickly. So it's kind of why the little allocation of mental health is mental health a poor relation, and would you agree that it's actually having the opposite effect? By spending less on it, we're actually putting further pressure on the rest of the health service and making the situation worse.
But the point I was trying to make is that we're increasing both in real and proportionate terms the amount we're spending on mental health. So you referenced figure 6, funding in 2019-20 of 298 million. The funding for 2023-24 was 388 million. So that was 7% as opposed to 5.7%. So that's a step in the right direction. Would it be desirable to do more? Absolutely. But I think I heard you, but maybe incorrectly, to suggest that the amount we were spending was going down, and that isn't the case.
The report clearly states it is gone down in percentage.
But the report is from a certain point in time, and I'm giving you more up-to-date information. It's not that I'm disagreeing with what's in the report.
Okay. So should the department then be setting a target around mental health and the share of the budget, and actually working on a plan of working towards that to match the rest of, or match GB, and put in a time frame within to do it?
I think that would be a matter for a minister. A minister could take that decision. I'm not sure it's a matter for a department or a permanent secretary to make that call.
Okay, thank you, David. Cheryl?
Thank you, Chair. I suppose I just wanted to pull off a point there from David. He just talked about the voluntary and community sector, and it's great to see that that's being recognised. One of the responses from the Department of Health was around a mapping report of current crisis services, including community and voluntary sector. Can I ask, has that been finalised yet?
Can you just remind me which report you were referring to there?
It was a minister's, Department of Health minister's response to a question. Regarding to ask the Minister of Health what action is being taken to help people in emergency mental health and addiction crisis, and the response, a lengthy response, but within it detailed a mapping report of current crisis services, including community and voluntary sector, is currently being finalised. So it's just checking, has that been completed?
So, look, I haven't got the question in front of me, but
I can help on that.
If it's the regional mental health crisis service, then if Brendan can say a little more about that.
Yeah, it hasn't been finalised yet. A workshop is planned for May of this year, 30th of May, which is going to bring forward the finalisation of that, and then subject to approvals, then it will be approved at that stage. So it's nearly there, but no, it's not finished at this stage.
No problem. And sorry, can I just confirm that's with all the stakeholders then from the voluntary and community sector would be at that meeting yet? And when does it, in terms of communication with the voluntary and community sector, I suppose one of the things I hear is a lot of these meetings happen during the day, and a lot of community and voluntary sector actually are working with the nature of their job. How do you work with them to ensure that their views are being taken on board, and obviously that they can deliver for yourselves?
Well, we try and involve the community and voluntary sector widely in a whole range of different work, not just in relation to mental health. And if individuals come to meetings and say that they're having challenges with the approach we're taking, then we would try and work with them to find to set future meetings up in a way that works for them. But many, there are a significant number of those organisations who do have employed staff who therefore can accommodate office hours. But where that's not possible, we'll always look at alternatives.
And what is one of the main barriers or challenges that you're finding with the voluntary and community sector?
So what are the challenges?
Challenges or barriers that you're finding?
Well, I think Peter kind of drew out the direction that we're trying to take here to recognise there may still need to be contractual relationships in relation to the delivery of services, so that we can be assured, and I can be assured as the accounting officer, that we're getting proper value for money, but that alongside that we develop the right sort of engagement relationship with our community and voluntary sector partners, so that we understand where they can add the most value, and we can listen to their views and take them into account in developing the strategies that we have. And as I said, I think that has largely been the case in relation to mental health.
Could I just add to that? One of the challenges that we've found, because we've been, since the development of the strategy, one of the biggest challenges for the mental health sector is the breadth of providers, the sheer size and scale of it, because you have some providers or organisations whose sole focus is mental health, but you've got others maybe who isn't, but they do mental health work as well. What we've found challenging is getting that coherent voice. Who speaks for the sector? Where can we get that meaningful feedback that is helpful and will ultimately benefit the people that need services. So we have been engaging about how do we get that, how do we support the sector to engage better with us. How do we, is there a way, do we need to put some resource in to help bring them together? Or I think there are a number of different options that we're going to explore, because I think getting that right then unpicks all that other stuff that I mentioned and that Peter has mentioned. But that's been our focus to date is, again, just as I said at the very start, putting ourselves in a sound footing, and that I naively went into it saying, come on, let's speak to each other, and then you realise, wow, that it's not as easy as that, and we need to do it in a more structured way. But I'm comfortable, as I said earlier, that's a priority for us because we need to crack that.
Yeah, no, and just you mentioned there about value for money, and probably the best value for money you'll ever get is the voluntary and community sector. But one of the barriers that I hear from the voluntary and community sector is the strenuous reporting that they have to do and accountability, which of course has to be done. But I suppose we're seeing within the data that maybe that's not to the level within the department. So there's a bit of a breakdown there. So have you looked at reviewing any of the reporting for the voluntary and community sector or additional support for them?
I think, at a high level, you're right to say there's a balance to be struck here. But if we didn't have enough evidence that the service was being delivered, that was being bought, then, whether it be through internal audit or external audit, then, we would rightly be held to account for that. So we do have to get the right balance. But I've always been clear with organisations that I've worked with that if they identify that we're asking for information they think has no value, then they should draw that to our attention, and we can then look at whether or not there's another way, either of not collecting that or of collecting it in a different way that makes sense. That would be at a high level. I don't know whether there are any specifics that you wanted to draw out.
No specifics. That's a particular issue, a very practical issue as to how we change the relationship between ourselves, that we're not counting every appointment or whatever.
Can I come in? I think one of the opportunities that lies ahead for us is through the implementation of the next phase of the outcomes reports. We're working towards the implementation of the outcomes framework within statutory services, because obviously that's where the greatest majority of activity currently occurs. But the next phase after that would be to look at the CMV sector and to really try to rationalise and to have a consistent framework both across statutory and the CMV sector. And I think that'll be really helpful. I think it's a really important point that you make.
Thank you.
Thank you, Cheryl, and thank you, Dr. Carr. Just to follow on briefly from what David asked earlier in relation to some of the funding questions, should the department not set targets around increasing the mental health share of the health budget towards matching levels elsewhere in the United Kingdom, and what time frame within which to do this?
So, as I said to Mr. Hannaford, I think that's a matter for a minister to determine, and if they wish to set a target, they're entirely within their prerogative to do so.
Okay, Diane, for Forsyth MLA.
Thank you, and thanks very much for your answers so far. The area I'm going to focus in on, we've mentioned it a few times, is data and outcomes. And just before we get into the cold, hard facts of the numbers and data, I just want to make the point that the importance of gathering correct data is that we can make comments on successful outcomes. And I was just struck today by a few members whenever they asked, what have we done so far in the 3 years? It's been answered with, we've spent money on this, we've progressed 20 out of 35 outcomes. It would have been nice to hear an estimate of how many lives may have been saved over the past 3 years when we're in Northern Ireland sitting with over 200 deaths by suicide a year. And it's just important to, in my opinion, bring this into the room as to what we're actually talking about here. So it's
very hard to prove cause and effects in those those terms. So I can give you statistics in relation to suicide, and actually last year there were fewer suicides than the year before. But what I wouldn't want to do with any confidence is to say that reduction is purely down to actions taken, for example, on the mental health strategy. And I think that would be impossible to do that. So data is I'm not clear that data will ever answer that question in those terms. But I'm very happy to come on and explain what we have been doing.
No, absolutely. But just wanted to make that point to bring back the very real situation we're dealing with here. So just with regard to the Northern Ireland Audit Office report, it highlighted very much that the current data is not providing a complete picture with regard to effectiveness of services. And last week the mental health champion brought evidence here and reiterated that, and she noted that for her as a professional, she found so many gaps and inconsistencies on what's reported by the Trust, she has had to gather her own data. Yeah. And I just wanted to ask then, as accounting officer, are you comfortable with the current level of spend of £350 million a year on these mental health services when you don't have clear evidence of what you're getting for that money?
So I think there's a couple of different dimensions to that. So there are, we have internal assurance frameworks within the department and with our providers, which are designed to look carefully at the way in which money is spent and whether we get value for money for that money. And I referenced already, but the work, for example, of our internal audit and external audit, those are two of the fundamental ways in which that assurance is provided. We also have recently introduced a patient-level costing system through the Strategic Performance and Planning group part of the department. And while that's still being rolled out, that will give us the ability to benchmark, including benchmarking with GB around the outcomes and performance that we deliver. And then we mentioned that perhaps the biggest initiative here is in relation to outcome measures, and that's being incorporated into the new Encompass system, which is being rolled out at the moment. You'll know it went live in the South Eastern Trust last November. It will go live in Belfast in June, in the Northern Trust in November, and in the Southern and Western Trusts in March of 2025. And what that will do is, and that the data should be available from this autumn for the first of those trusts, and that will enable, for the first time, really coherent measurement across trusts around performance. And those are only some of the steps that we've taken. I can also describe a number of other steps that have been important steps that have been taken, both to gather information together and to put that information more into the public domain. So do we have more to do? We absolutely do. But I think, not least helped by the Audit Office report, we have had a real focus on that in the last 2 or 3 years, and we've made a lot of progress.
Thank you. But again, a lot of these are targets for improvements in the future. And I'm just asking, are you comfortable with the current level of spend of £350 million in year before these improvements are made on mental health services as accounting officer?
Well, I've already been asked whether there shouldn't be a lot more money spent on mental health, and agreed that it would be desirable to increase the total spend on mental health. So that's part of the answer, I guess. But as I said, I'm confident that there is a sufficient level through our internal assurance framework that enables us, and Brendan might want to say something about the work that the SPPG does in terms of overseeing and managing the performance of the 5 trusts who are the main providers of these services, to help give you more assurance that we do understand exactly what's going on, and we have clear line of sight in terms of that. Brendan, would you like to say something?
No, happy to give some further clarification. There is significant data which is collected. The data that is collected is frequently activity data in terms of the service. So it will be the number of people that are seen, the waiting lists, the breaches, the throughput. And so we I think earlier on in the session, there'd been a query about whether the robustness of that information. I am satisfied that information in terms of which that's received from the 5 trusts is robust. So on a monthly basis, we get the activity data. Where there's variance between one trust and another, that will mean that staff within the strategic performance group will make contact with the trust to understand the variance, or if there are waiting lists are not at the rate or different from one trust to another, that will be followed up. However, where I completely acknowledge, and the strategy has acknowledged it too, is that's activity, but it's not the outcomes piece. And the outcomes piece is what difference has made to an individual before they received treatment and afterwards. Now, what we know from Dr. Kaur and from the other trusts is that at a trust level, then before and after measures are captured by clinicians. So they will look at wellbeing scales, they will look at outcome scales for clinicians. Our ambition for the future is that the strategic outcomes framework will enable us to aggregate that together so that we can take a holistic view of how well we're doing. Now, the real prize for us all will be if we can do that not just across statutory, but across our community intervention, so that we can see where we're getting the best value for our investment. So in terms of our assurance today, absolutely, in terms of the activity that's provided by the trusts, are people working hard? Are we seeing the activity? Do we know what we're spending the money on? Yes. However, in terms of the outcomes, that's at a clinical level, and that is our ambition is to lift that up in terms of our planning level.
Thank you, and but I do feel like you've clarified the point that I was trying to tease out there, that you're spending money and you're measuring that people have walked through the system, but you aren't currently measuring at a high level outcomes to show that you're getting value for that money. You talked there about the different levels of trust, and I appreciate Dr. Corr's comments on the Northern Trust. I just wanted to ask, and referring back to last week in the Mental Health Champions output, and again I refer to the fact that she's a professional struggling to use this data to compare it. I just want to ask you, is there a consistency in the data coming through from all trusts?
There's a consistency in terms of the data which is coming through to the Strategic Plan Performance Group on the performance and on the activity levels. If I heard the Commissioner correctly last week when she was given her evidence, it was in relation to, I think she made comments with regard to freedom of information requests from journalists and others. And there's a challenge in terms of the question that's asked. Are you, and then how do you make sense of the answer if it's asked in different ways? I can't comment about what's being asked in that way, but what I can say is...
The point I wanted to ask on it is, is there consistent data coming through to you, and are you reviewing it as a department for any regional disparities? So is there particular mental health crises in certain areas and certain trusts that requires targeted spend?
The answer is yes, we are consistently looking at the data coming in across the 5 trusts with regard to the activity, the waiting lists and the breaches. We do that on a monthly basis. There is a service delivery plan which sets our expected activity across each of the areas across HSE with regard to mental health. We've looked at how we would expect to see that activity increase post the pandemic period. We've been tracking that trajectory to see if it's going in the right direction. We're confident that it is. So in terms of are we measuring the activity that's coming, the answer to that is yes. And where there is variance or unwarranted variance, then that is picked up with trusts to understand, and if there's a need for a particular trust to take alternative or different action, an action plan's agreed, and we'd monitor that with the trust to take it through. So I'm confident in that regard. However, I would go back to the caveat, it's with regard to our activity, our breaches, and not with our outcomes. But we know that, which is why we want to develop the outcomes framework.
And we're well on with that. I mean, that is a matter of months away, having that in place.
That's great. And just wanted to refer then to the mental health strategy and how, given the limited data that has been available, how have we been able to end up with a strategy with 35 key actions formed on the basis of limited data to be confident of a baseline point and be able to accurately monitor our progress and how we're performing?
I think the answer to that is probably very similar to the answer that Brendan's already given, in that we do actually have robust data in a whole range of different areas, and that does give us a good framework. We are looking to grow and expand that, including through the strategy, in terms of how we develop our ability to have better data across the whole range of things. But for me, we know enough to have confidence that the recommendations that we've made in the mental health strategy are well based, and I think I believe that the Commissioner would broadly agree with that, for example, that they are the right areas of focus, as would the other people that were engaged in the development of the strategy. So I think when you have that kind of broad consensus, then I think you can take some confidence from that.
Absolutely, and you referred to the regional outcomes framework, so you said that's months away. I was just wanting to ask in terms of a timeline and a cost to implement to that, as it seems to be the answer to a lot of our data collection issues.
So I don't have a broken down cost for that because it's being implemented through the Encompass rollout. The Encompass is a tens, hundreds of millions of pound investment in health and social care. So it'll be bound up within that, and I don't have a specific for that. But it is currently being worked through. My understanding is that by the autumn of this year, the outcomes framework will be in place. Clearly, that will only work for those trusts that are on Encompass, and I've explained there's a rollout in the next 12 months. So by this time next year, all of the trusts will be reporting using the same outcomes measures using Encompass, and that should provide then that level of interconnectivity right across all 5 trusts that I think you're aspiring to.
That's great, and I just wanted to clarify, will the proposed outcomes framework measurements be embedded within the Encompass system, or will there need to be a further action to extract that?
They'll be embedded in the system.
So they are. We are. Kind of just to elaborate on what Peter's just said there, that the outcomes framework is there. It's been developed and approved by the Minister in October. It's about when it's actually available, I suppose, and that's very much tied in with the Encompass rollout. So it is there and it's being embedded. What we have is regular meetings. So as well as developing the outcomes framework, we've also developed a range of outcome measures. You know, they are universal measures, which test the overall mental health of an individual, and that's well-known tools such as the Work Edinburgh Mental Wellbeing Scale or Kids Screen 27. They're universal measures. You've then got some very specific measures built into that are being embedded within Encompass. For example, health anxiety and inventory, the Rosenberg self-esteem scale, eating disorder examination, and also just some stuff here around substance use and alcohol use. So they are being embedded. We meet regularly with the Encompass team, or EPIC, the company doing it. There's a checkpoint with the individuals embedding that, and we have a checklist as to where each of those measures are in terms of being available for use within the system. There are some licensing issues around some of those measures, but again, that's all within a managed program to make sure that they're available. I know, Petra, you've been involved in a lot of stuff around that, so I don't know if you want to add anything.
Just to conclude, perhaps, I don't want to leave the committee with the idea that when Encompass goes live, everything is solved, because that isn't the way of the world. Encompass will... Sorry?
I was about to ask you that question.
Oh, well, I'm glad I got there first, Chair. Encompass will be a big step forward, but there will be a programme that's needed to build on what comes out from the Encompass. Once you've got the data, you then have to work out how to make proper use of it and so on. So there will be a programme over a couple of years in order to develop that and make that work. So just in case I gave the wrong impression that with one bound we'll be free, because that's never the way, I'm afraid.
Well, thank you. And just one final thing I wanted to ask. Does the department keep data on how many direct referrals of individuals are made from the department through GPs and trusts directly into the voluntary and community sector?
I think that's quite a complicated question, because there are so many different ways in which, or conditions that someone might have. I don't know, Dr. Cora, do you...
Not so much into the specifics and the measurability. The point I just want to make sure is captured, and I know you talked about on the review for the future and how to engage with the voluntary and community sector. I'm just really concerned that I know that it is thousands, and in some areas an awful lot more than others, and I just want to make sure that it's being captured. And I hope you have seen today this letter that has come out from 51 community and voluntary groups. A number of them, mental health organisations, Action Mental Health, MENCAP, are all on the list, and calling on the Health Minister to restore the core funding, because their organisations are at risk of collapse. And I just know from last year, whenever there was the cliff edge of funding, a number of representatives from different trusts were in touch with me to say we can only refer into these organisations if they were to collapse. We have nowhere to refer them. So I just feel that I want to make sure that this is highlighted as urgent, because if in this budget now that core funding, which isn't an awful lot in the overall scheme of things and the Department of Health's budget, if it falls and these voluntary and community sector groups cease to exist, do you know how many patients across Northern Ireland are going to have nowhere to access services, and immediately in 24-25 and before we can get further in this strategy? Because I'm very concerned that we're at crisis point. We're going to hit a brink, and if these organisations go, we're going to be left with thousands of patients that have nowhere to be referred to services.
Look, I understand, but I haven't seen the letter. You said it maybe only came today, and I'm afraid I haven't yet seen it, but I'm sure it'll be there when I go back to my office. It is correct that last year we were only able to pay 50% of the core grant, but the core grant was actually a very small proportion of the total amount that we invest in the community and voluntary sector as a department. The core grant is there designed to help people with their corporate overheads and so on, and to do any advocacy work that they need to do. We contract separately in terms of the delivery of services, and it's many tens of millions that Health and Social Care collectively invest in the voluntary and community sector in that way. and those amounts weren't cut last year. So I'm not minimising the challenge, and I recognise the concern of the voluntary and community sector, but in context, the total amount that we invest remains, a very, very high proportion of what it was, and there tends to be a focus on the 1.75 million that wasn't made available last year, and I just want to draw out that the actual service provision is tens of millions, and it's that you're concerned about, as I would be.
It's just, I wonder, would you accept the point that the collation of the data on this would be something that the department perhaps should be gathering as a matter of urgency to clarify, quantify the scale of the impact the voluntary community sector has on the delivery of mental health services in Northern Ireland, to ensure that it's a key part of the priority, and that these organisations, beyond the core grant funding, throughout all of their funding, that they are secured as a key priority of the department.
So we'll obviously have that information on a point-by-point basis, but we don't collect it all together in one place.
And as well, and your review and engagement with the voluntary community sector, will that include development of a means to gather data from them when they aren't funded by the department? I've spoken to a few local organisations, and because they don't get direct funding from the trust or the department, they actually don't give their data anywhere, and they provide significant mental health services in the greater Newry and Mourne area. So I just wonder if that engagement would include a way to capture that, whereas they're not directly funded by the department, but they're providing some essential services.
That's not something that I've sort of been made aware of as an issue, but I'm happy to take it away and for us to look at what's possible in that area. Inevitably, there may be some complexity, but let's see even if we can do some of it. It may be an improvement. So happy to look at that.
No, absolutely, and thank you very much. It's just, if we can't gather all the information, take it and use it in a meaningful way. We're just spending money and we don't know what we're getting for it, and we're calling for here in this report for £1.2 billion, which is a significant increase. So we need to be very able to stand over what we are getting for the money we're already spending here in Northern Ireland before.
And I hope what we've said has given you some assurance that we do know what we're getting for the money that we spent.
Thank you.
So, some very important questions there, Permanent Secretary, from Diane. The data collation issues are of concern to all members of this committee, and we've had a number of conversations in relation to it. And I know that you've answered a few questions in relation to Encompass, but I know one of the criticisms is about its limitations, particularly GPs and primary care can view patient records, for instance, and make referrals, but cannot update records, which is a challenge. So basically, what's been done in relation to that to ensure that Encompass can properly cover all of those various gaps that are there, and are you assured that that will indeed be the case when it is rolled out?
So the current plan is to roll it out within secondary care and within the 5 trusts. And what I would say is that it's the largest single change programme that health and social care probably has ever faced, because it involves every individual who has contact with a patient having to change the way they work pretty fundamentally many times every day. And as a result, this is a massive enterprise, and getting it right in secondary care will bring about huge benefits and move us forward in a lot of different ways, including, importantly, benefits in terms of safety for patients. You are right that there are always going to be interface issues. You mentioned GPs. The independent sector is another interface area. And what I would say is that we will need to look, after we have completed the rollout in the trust, to think about whether there is sensibly further that we can go. We are already the most ambitious region anywhere in terms of what we're seeking to do, because we're doing the rollout of Encompass on an integrated health and social care basis, and that hasn't been done elsewhere. They've done a little bit of social care, but they haven't done the two together. And so, this is already a very significant change program, and change programs always bring with them risk. So it's important to make sure you get the right scheduling and scope for that program at the start, and then by all means let's look and see whether it's possible and sensible to do more, but our ambition at the moment is to make it work in secondary care in the first instance.
Okay, I appreciate that. I do hope that that'll be resolved, because We can't have situations where GPs can make referrals but then can't update whether or not that person's been treated, what the outcome is, and it creates an issue.
If they've made a referral, then it's the hospital that will update their records, and the GP will have access to that, be able to see what has been done as a result. That's one of the advantages.
Okay.
It will cut down on the need for letters and all of those things.
Okay. That's grand. We'll go to...
we questioned it. Follow up from there on. It was quite interesting, just to bring it back to the focus of this group and what we're doing in terms of mental health inquiry. I just want to ask out straight, I mean, how did we develop such a strategy without information on workforce for delivery, information on funding, which we don't have, and also information, as Dion said, in terms of data on those three things? How did we develop such a strategy?
Well, a good part of the strategy is to set out where we need to do more in order to put in place things. So one of the actions was to do a workforce review, and that has now been completed. So that was recognised as something that needed to be in place and wasn't in place at the time of the strategy. It's like a lot of these things.
But Peter, that brings me back to the baseline. So then our baseline must have been very, very low in terms of information, all those things we had. That's the point of the question. So where was our starting point in terms of our baseline?
So I think it's recognised that the return of an executive and a Minister of Health in 2020 brought a new focus on mental health, and the mental health action plan and then the mental health strategy have moved us forward very substantially from where we were before. So, I think that is a recognised widely, and what we're doing is trying to make sure we do have solid foundations across all of the different areas.
Can I come in?
Yeah.
I'd be keen to offer a level of reassurance that within trusts we do have significant amounts of data. Yeah. I know exactly what my workforce are. I know the professional breakdown. I know the gaps. I know the vacancies. I know the sickness absence. I have the performance tools. I know where my breaches are, and this is the same for all of my colleagues across the 5 trusts. We do have a robust set of data. There are issues that are referenced in the report that speak to inconsistent approaches in structures which make it difficult to compare, for example, with the Northern and the Western Trust, or Northern and Southern, or Northern and Belfast, because actually we call things different names, and we also have our structures organised in slightly different ways. So some CMHTs may do some things and others do slightly others, and may have sort of congregated functions. So I think one of the key opportunities that the mental health strategy and actually the foundation and enabling works of the mental health strategy will enable us to do is to bring consistency across all of the postcodes in Northern Ireland to what we're doing and what we call it, to allow us to then ensure that the data that I collect in the Northern Trust and that my colleagues collect across other trusts are very easily compared. But I think it's really important for us to offer a level of assurance to you today that I have significant and robust data that enables me to safely manage my services, both in terms of workforce, in terms of governance, in terms of safety, and in terms of our performance and our outcomes.
Well, I'm sure it's not a criticism of the workforce or a
No,
strategy.
absolutely. But
I mean, we're just trying to delve into exactly.
Yeah, but the data as Petra's described, we had all the data on how many people we had in the workforce in 2020 or 2021. What there wasn't was a clear analysis about what it would take for the future, and that was the purpose of the workforce review. So it was a future pointing direction as to what was needed if we were going to address all of the problems in mental health going forward.
And just to build on Peter's comment, the workforce review is a very helpful evidence-based and forward-looking document, and I feel that, and there's been very significant engagement and involvement with a whole range of professional groups and with all of the providers around the workforce review. So I think it is a very helpful framework for us moving forward. So I suppose just to lend support actually to that as a direction of travel.
Thank you, Dr. Corr. And just to follow on a wee bit in relation to this before I come to John, who's been extremely patient. in relation to the collation of data across the trust, if different things are done in different ways and they're not consistent across trusts, how can you see the full picture with the data that's there? Surely there would be gaps.
We have agreed, sorry if I can just immediately come in.
Of course,
with a level of enthusiasm. We have agreed data definitions that come to us from our colleagues from SPPG. Right. And so therefore we all count the same things in the same ways. So we're quite clear in our data definitions so that we know that structurally things look different and they're called different things and they're organised in slightly different ways, which makes it really difficult. And we appreciate that, which is why we're all very committed to the sort of centralised and consistent approach within the mental health strategy. But just to acknowledge that those consistent data definitions are there. So when we look at, and when Peter has given you data on waiting times, for example, in CAMHS or in mental health services or in dementia services, we have a clear set of data definitions that colleagues at SPPG manage with tenacity.
Yeah, just a supplementary point to that, and because you've mentioned the waiting list data, the only trust that this has been rolled out into date, it's my understanding that they're saying that it can't provide any waiting list data. Is that Encompass I'm on about? Is that the case as well?
So the South Eastern Trust is the trust that was gone live first, and we have taken longer than we had hoped to be able to produce full data from the Encompass. It's getting the right comparability so that we can be assured that it's on the same basis as everywhere else. But huge progress has been made in recent weeks, and we are now receiving through SPPG, the part of the department that looks at the performance, we're now receiving over 90% of the data sets that we need through Encompass, and I believe that mental health are among that 90%.
So just very briefly, Permanent Secretary, and I appreciate your answer to this. So this is rolled out in that particular trust. This issue has been identified and there's been moves to improve the access to that data. Is that what you're saying?
Yeah, what I'm saying is there was a comparability issue with what was being counted on Encompass being the same as what was being counted by other trusts, and we've been addressing that, and once it's addressed for one trust, it'll work for all the trusts. So that there's an advantage. There's always more sort of snagging with the first trust to go live in these situations.
It literally just was a snagging issue.
Yeah.
Okay. John.
Sorry, just a very small point on the data. Just to pull it right back to that case that I mentioned to you, because and this is around the data. So it says in paragraph 4.22 of the auditor's report highlights some frankly unacceptable waiting lists, and I'll quote here. Longest waits, and this was in March 2022, coincidentally, which was the same date that I was speaking about in terms of my constituent. Longest waits in adult mental health were around a year, 321 days. But I have that email stating that it's a 5 year. So how can that marry up or tally up in terms of data?
I think it will depend on the condition that's being concerned here. I don't know, Dr. Cole, you'd be more expert than I am, but not. There are lots of definitions, I think.
I think the overarching picture that you gave, Peter, at the beginning that Colm you're referring to was for adult mental health services, and that the Audit Office report, there are specific waiting lists for specific conditions that may have differing waiting times. So it may well be a specific condition that has a particularly long wait.
And I guess we can all agree that's absolutely unacceptable. I wanted to focus on the data part of that. Sorry.
Thank you. John Stewart.
Thank you, Chair, and thanks again for coming along today for your answers thus far. I want to touch on CAMHS. I know in many of your answers so far we've overlapped into that with the nature of the questioning, but I think it's important to dive specifically into the topic itself. So we'll start with the first side around the funding. Paragraph 3.19 of the Audit Office report identifies that the level of funding for CAMHS services was 7.7% of the mental health budget for 21-22, short of the 10% budget that you'd set out within the strategy. Just curious to get why that is the case, what the current percentage of funding for CAMHS is, and what impact the underfunding will be having on vulnerable young people as a result.
Okay, thank you for the question. The current level of funding, sorry, I'm just trying to find my appropriate, so it's CAMHS is 8% of the total mental health planned expenditure. We're currently investing 30.7 million, that's in 2023, 2024. And the reason that we haven't achieved the 10% is very similar to the discussion we had earlier about how it would be desirable to invest more in mental health more generally, and it's where the new money is going to come from in a world where we've not had new money in order to invest because of the very serious pressures on our budget for the last 2 or 3 years, which look like persisting. And that is the thing that is restricting the ability to increase. But we did highlight that we'd invested, I think I used 2 million, 1.9 million of the mental health strategy money in extra CAMHS provision, particularly in the inpatient setting. And at a recent visit to Beechcroft, I could see the difference that makes in terms of the way of working. And I talked to some of the staff on that occasion.
So to try and quantify them, that we're spending currently 20% less on CAMHS than we'd want to be, effectively. We're spending 8% out of 10. So I'm just curious to know how that's being ruled out on the ground in terms of what services are not being delivered that should be delivered if the full amount could be being spent. Is there any way to quantify that?
Well, I guess what the logical and clear consequence of that is that there isn't the same capacity within the CAMHS system, and I referenced the fact that I think it was 1,100 people are not being seen within the 9-week target. They will have been triaged before that, but they're not actually getting the treatment that they deserve. And what we have seen as a result, not least I think, but particularly of COVID, is increased acuity, particularly in children and adolescents. And particularly, for example, to use one statistic, the percentage of eating order admissions into the general adolescent inpatient unit has nearly tripled in the last 5 years. So that's obviously a much greater problem proportionately than it was before. Probably made worse by COVID, where there was less interaction with peers, less opportunity to catch that early, and that's meant that more of those people are facing more severe challenges which take longer to address and resolve through our mental health services.
Okay.
If I might add, when we look at the number of referrals that are coming into the children and adolescent mental health service, what we know is that children are frequently being treated for longer, and that's to do with the increased acuity, the condition, the treatment tail that goes with them. So children who are coming in with eating disorders or psychosis, these are issues which require a significant level of support to the child. That means that whilst people are staying in the service longer, the demand on the service increases in terms of we continue to have the throughput through in terms of referrals, but the children that we treat are being treated for longer, which means the activity the workforce is doing is greater.
Okay. That leads me on to my next question then, because the report also says that there are lower levels of referral acceptance within CAMHS. And in our discussions last week with the mental health champion, she suggested that reflects what's termed inappropriate referrals, people's problems not being severe enough to meet the threshold, but yet children's conditions continue to deteriorate in that time. So I'm just wondering what more can be done to get earlier access and intervention, given that we talked about last week with the mental health champion, invest to save. If we can get in early and treat and almost nip these issues in the bud as quickly as possible and give access to mental health services to young people, is there a case for invest to save within that, and what more can be done to open up access to CAMHS?
Currently around 70% of referrals to CAMHS meet the criteria, and in adult mental health services that number is closer to 85%, so there is a gap.
Yeah.
We did reference that in relation to the mental health strategy, there had been investment in early intervention services, and there had been a 3-year plan put in place in relation to that. But I think we would all agree in principle that the more we can, to use the jargon, shift left, move things out of the acute setting into the community setting, into the to have issues addressed before clinicians need to get involved, and so on. That would be desirable, and a lot of work is done to try to increase the amount of material that's available both to children, young people, and to their parents about the kinds of approaches that can assist. Do we have more that we could do? I wouldn't disagree with that at all. There's always more that you can do in that space, and it is absolutely the right direction of travel. But But it brings us perhaps back to some of the questions we can ask. A lot of that would be the community and voluntary sector perhaps providing those services. It wouldn't be looking to necessarily involve clinical psychologists or whatever in that work, or clinical psychiatrists in that work, should I say.
Okay, thank you, Permanent Secretary. The next aspect, again, leads on to that, is the data from Children's Commissioner indicates that the number of children receiving emergency referrals to CAMHS from A&E departments has doubled between 2018 and 2021, and I believe it's continuing to grow. We've already discussed through the Chair that I think we accept that emergency departments are not the best place to treat mental health issues, particularly with young people. So I'm just wondering what this increase is down to, and what more can be done. Is there a failure within CAMHS, for example, to deal with that, and why they're ending up at actions of emergency as opposed to other services?
So I don't believe that this isn't a failure of CAMHS. I've indicated, I think, that COVID in particular has led to increased acuity because in a range of different ways. I used eating disorders as one example, but there will be others. And what's happening is people are presenting with much more serious illness than would have been the case previously. And that's probably because of the fact that they've been isolated during the lockdowns. They've not had the same exposure to either people outside their family or to friends or to others who might spot an emergent problem. To give you one statistic, we've seen the number of young people detained under the mental health order rise from 18% it's increased by 7% from 18% in 2018-19 to 25% in 2022-23. So if you're being detained under the mental health order, that's obviously a much more serious illness that you're experiencing. If they're approaching in a crisis context, it may well be that CAMHS haven't been involved previously, and that's so it's not that they failed. It is that people are emerging with much more serious problems.
You might not have this today, but is there data, particularly on this, as to how many of those who have presented to ED were originally in contact with CAMHS, and also of those who presented to ED had been turned down for CAMHS, in terms of whether they fell into that 30% of people who'd requested assistance but didn't qualify?
I don't have the data about those numbers.
Okay.
Happy to look. I don't know whether we collected or not. I'm happy to look and see. Did you want to?
If I could just add, certainly I don't have those numbers, but in terms of the 30% that don't meet the criteria, that 30% are not left, because one of the issues that in terms of discussion with the service during the week was, what's the workload, what's the tail in terms of that 30%? That 30% are followed up in terms of making the appropriate referrals. Now, they may well indeed end up going to the community and voluntary sector and being referred in that direction, but it's not that the shutter goes down. There's actually an appropriate referral pathway then for them to get the support that they need.
Okay. If there's any more
and they would be lower level dependency at that stage than the ones that are accepted.
I will see if we hold the data on the number of young people who appear at an emergency department with a severe mental health problem who have already been through the CAMHS service, and I'll see whether we hold
useful.
That.
Would get that.
Potentially helpful to note that CAMHS services do have a crisis part to that service as well. So just to acknowledge that there is a recognition that on occasions there can be a rapid deterioration in a young person's presentation, and as a result of that there is a crisis pathway into CAMHS as well that facilitates that easy access, and that can be supported through the ED as well as through the CAMHS the processes within each trust.
Just one last point on this, Chair, if that's okay. Just curious, Permanent Secretary, if you could tease out the referral pathways for CAMHS, and also what roles schools are currently playing, and what more could be done in a collaborative approach between the two departments to make that easier in terms of referring from the schools into CAMHS itself, and also what other channels are open given the pressures that are on GP surgeries currently. And the Chair's already outlined, as we all know, the difficulty in getting an appointment with a GP, so are there other avenues that can be pursued there?
So we are doing a lot of work with the Department of Education jointly. We published a Children and Young Persons' Emotional Health and Wellbeing in Education framework in 2021. And the main emphasis there is to support educational settings to promote emotional health and well-being at a universal level through a holistic and multidisciplinary approach. So that's one of the areas. I actually have a long table which I'm not going to try and read out because tables don't make for good reading. But other initiatives include the Health and Education SEND partnership pilot to improve outcomes for children with special educational needs, the Sure Start Speech, Language and Communication Service, which is a regional programme commissioned by the Department of Education in partnership with ourselves and the Public Health Agency, and a Belfast-wide early years project, which is currently being developed and piloted in the Belfast Trust in relation to Sure Start, aiming to promote opportunities through play to encourage children to develop emotionally, socially, intellectually and physically. So that's just a flavour of some of the collaboration that we have with the Department of Education. And obviously schools are one of the key ways in which if problems are beginning to manifest of a mental health nature, then there were established ways in which teachers and others can contact statutory services in health in order to seek assistance and support. I don't know if there's anything...
I was going to just draw out something from the table. Peter.
Please do.
No, I mean, the framework is the overall way in which we're working with the Department of Education in relation to schools, but there are a couple of important I suppose initiatives from within that we're leading on from the health side. And Peter mentioned it earlier in the session, and it's the emotional wellbeing teams in schools, which is a really important initiative, multidisciplinary team working in a post-primary setting by promoting emotional health and wellbeing and ensuring schools are aware of the appropriate pathways to support. So that's a really, and then we've got staff in trusts dedicated to providing that service. So it is about being preventative. It's about working with pupils and staff as well. And again, the whole aim of this is to reduce that risk of longer term, more severe conditions developing. Currently working with 46 schools, which is a good start, and we're planning to work with 68 schools next year. So that's an important initiative around making sure everyone's clear at a school setting as what pathways are available and really building that knowledge base as well. I suppose that's the main one. There are lots of other, and we can give you more if you'd like, but there's some really good initiatives under that framework where we're trying to get ahead of the curve in that regard.
Chair's probably sick of me saying about invest to save, but it's such an important aspect because particularly when it comes to child and adolescent services, it would be great to see the data on how successful those schemes are and the overall saving that could be made year after year at early intervention stage. I mean, we know that the impact of mental health here is over 3.6 billion, I think we heard, per year. It's massive, so the more we can put into this at the earliest possible stage, the better. It would free up so much logistically for the department and free up so much more in terms of the system as well. So I just think it could be a game changer in that respect. Thanks, Chair. That's all for now.
Thank you, John. And just to follow on from a couple of John's questions, for instance, there's a bit of disparity between trusts. So the Western Trust, 83% of referrals for CAMHS support are accepted. Belfast and South East Trust, only 70% are accepted. Are all trusts applying similar tests to identify acceptance, and is there a disparity provision between each of these trust areas?
Well, they will all be applying the same guidance for cases, and there could be multiple reasons why there are different levels of acceptance or rejection of cases. But obviously, it's part of what we would like to achieve is to reduce the number of cases that don't meet the threshold, because the threshold should be understood and known before a referral is made. So that's an ambition that we would have. As I said, in adult mental health, it has reduced quite significantly in recent years the number of cases that don't meet the threshold. But there's the same rules that apply for everybody.
Just by way of clarification, all 5 trusts operate the regionally agreed threshold criteria. So there's no difference between the 5 trusts in terms of the criteria that they apply in order to be accepted into the CAMHS service, either step 2 or step 3.
I'm just wondering when you look at the actual numbers, 83%, as I've said, in the Western Trust and only 70% in some of the others. That's a 13% of a difference, which is quite significant when you drill down into the numbers. So why are so many referrals being turned down on other areas? Do we know?
I don't have a detailed answer to that, I'm afraid, Chair.
It would be helpful if we could find that out, because
I can certainly find out the main reasons why cases aren't seen to meet the threshold. It may be more difficult to understand why those cases are coming forward, but I'll see what we can find out.
Okay, that's very helpful. Padraig Delargy, MLA and Permanent Secretary.
Thank you for your presentation, folks. My questions are fairly straightforward, two of them. So just to let you know, the first one is on the finances of interventions. And the second one then is just around the early intervention and your links with education as well. So in terms of the finances so far, I would just like if you could give me a breakdown on how much you're currently putting on the early intervention. And if you could compare that to how much you believe is needed for early intervention, please.
So the data I have relates to how much we're funding through the mental health strategy. So there's currently £1 million allocated for 2023-24, and that has enabled 268 family referrals to the early intervention and prevention service, 70 children and young people with complex needs to be engaged through individual and group sessions, and over 2,000 people to have registered online courses for parents. So that's the allocation there. There will, I'm sure, in the existing mental health budget be other monies that are used for early intervention, which I have not got that data, and I don't know how easy it is to break it out, but we can look and see whether there's anything more that we can offer there. The second half of your question is a difficult one in the sense of saying how much we ideally would need, but I don't know whether the mental health strategy in that 10-year costing broke out how much for early intervention year on year or not, Peter. Do you remember?
No. And I think it's because of the very nature of early intervention and prevention. It goes across so many different aspects of work. So whereas Actions 1 and 2 in the strategy was about developing an early intervention and prevention action plan, which we have done, and that's the £1 million that Peter was talking to that we've allocated to that particular aspect. There's a whole range of activity that's going on that involves shifting work, to earlier in the lifespan. So, for example, we just talked about the work with the Department of Education in the emotional wellbeing framework. That's jointly funded between the two departments. DE have committed to providing between 4 and 5 million a year. We provide £1.5 million per year. The range of activities that funds is preventative. It's absolutely getting in early in the lifespan to try and stop conditions developing. So I talked about emotional wellbeing teams in schools. We do have a text-to-nurse scheme, which I'm sure many of you have heard about, in the post-primary setting, and also a regional integrated support for education, which is working in the primary school sector. So it would be, I think, a job of work to pull together everything that's preventative. One of the actions in the early intervention prevention action plan, I think, is scoping the activity that goes on, because that's just not limited to Department of Health. It's absolutely cross-departmental, and it goes across every department. And I think what surprised me whenever that work started was the sheer breadth of activity that's already happening right across government, right across local government, and across every sector. So I know they're trying just to scope that, but in terms of pulling it together into one number, we haven't done that.
Okay, so I'm just asking for, sometime over the course of this inquiry, if that could be pulled together. I think that would be really useful for our information. The other thing, and I appreciate you probably won't have it to hand, but it would be great if it could be delivered over the course of this inquiry as well, is when you've mapped that and when you've mapped how much is spent on early intervention in the whole, it would be great to see a comparative to that over the course of several years now, say from 2018 onwards, 2019 onwards, just so that we can actually monitor how much has been spent, whether that's increased, how effective that's been, So I think that data would be pertinent for us in this inquiry. The second question then touches on what you've just mentioned, which is around that cross-departmental working. And I think that is essential. For me, I used to work as a primary school teacher, so I'm very much aware of what we see in schools in terms of the increasing need for mental health support, particularly at that early intervention stage. And as you've mentioned, in a preventative approach as well. I also chair the all-party group on mental health, and we've recently commissioned a report which I know you've been involved in, and that's around early intervention in schools, because one of the things that we had continuously seen was a disparity between schools. Some schools who were putting a lot of resource, a lot of time, a lot of energy into well-being and the mental health and a preventative curriculum. Other schools who just maybe didn't have the capacity or the skill set there at present to do that. So I think it's important that we're supporting schools in doing that as well. And as you say, that all comes together in a preventative place. So firstly, I would like to invite you formally to the launch of that report. I've sent you through, or an invite has been sent through from Mindways this afternoon, I believe, actually. Because I think that does work in that cross-departmental thing and to ensure that we're not working in silos. But I'm also very keen to hear in that what work you've already done with the Department of Education and what work you plan to do in the time ahead to ensure that there is that collaborative approach.
Okay, thank you. So in relation to the request for the data around prevention, we will certainly look at what we hold. I think there will be some definitional challenges as to what counts as prevention and what doesn't, and that may also make it difficult. You asked for a 5-year sort of horizon, but we will be able to do some of that. So we'll try and at least offer you some examples, even if it's not a comprehensive picture. In relation to the work with the Department of Education and the work in schools, I mean, I think we would, in the department, be very supportive of the efforts that are made. I'm happy to look at the invitation that you've sent me and certainly make sure that the department's represented at the senior level at that event. The work we're doing with the department is multifaceted. I've actually run through a few of the areas, and I know Peter has as well, and I don't want to repeat myself. But one of the other areas of work that we've done with the Department of Education is the Life Deserves strategy for looked after children, because we know that is a particular community that faces real challenges in terms of life chances going forward. So our departments and our arm's length bodies are cooperating on the implementation of the strategy's commitments to action, including how we pool resources to support the implementation of the emotional health and wellbeing in education framework. And there are, as I've indicated, a range of other areas, including, for example, an education authority-led programme to assist all schools develop a whole school approach to emotional health and wellbeing, which is very much in the space that you've just been talking about. So that involves participating schools having a framework to assess emotional health and wellbeing policy and practice, to implement actions to develop that in their schools, and to receive training to provide staff with the knowledge, skills and confidence to understand and promote emotional health and wellbeing in their school. And that started in the last academic year and will be running forward into this year. So, there are other examples we can provide, but there is a lot of joint working. You can always do more, and that's the reality. So, we are, as ever, are constrained to some extent, but be assured that there are a whole raft of things that we are doing with the department.
Great, no, I appreciate that, and I'm aware of a lot of the work that you're already doing. I think when you're pulling together that 5-year, I suppose, spread of data, I think what's important for us is that when we've been looking at data in the past, it can be quite hard to find a consistent set of data. So it's measured against different variables. It's not consistent. So I think one of the things that would be really useful when pulling that together for the department is that you're using a consistent methodology, and also that we're looking at comparable factors across those 5 years. So to make sure that whatever is measured in year 1 is also measured in year 5, and it'll just allow us to have, I suppose, the best and most up-to-date data But thank you for your answers, and I'm looking forward to working with you in the time ahead.
As I said, we'll do the best we can. I think there will be some definitional challenges, but we can compare like with like in terms of programs that we're delivering now compared with programs, the same program 5 years ago, and give you that. What counts as prevention or early intervention, though, is a bit of a challenge.
Yeah, Padraig, thank you very much for that. And just as a point in terms of collaboration and early intervention as well, the post-primary schools are funded for counselling services, and there was funding available through the Department of Education in the Engage programme that has since been removed in recent times, and I do believe that's contradictory of what we're trying to achieve in terms of early intervention, and there's a huge amount of concern about those services being removed. I think it's important to put that on the record. Colin, you briefly want to come in there?
Yeah, something that hasn't been touched on, actually a crucial area, so I just want to put it on the record and get a quick answer from you in relation to this. The area of, and I first became aware of this through my work as a social worker, and I became ever increasingly aware of it, and it's dual diagnosis of addictions and mental health. And I am dealing increasingly with people who are being told by the service and have been removed from one part of that or the other as a result of the other condition. So they've been told, being like removed from addiction services until you get help with your mental health problem, but we have no service to offer you. And the same is happening in relation to the addictions. Do we need to, and that's just not fair on people, that the same service is bouncing them around and kind of located within the individual. Do we need to radically reform how we approach that entire issue to ensure people get joined up treatment for both those issues where they arise, given the correlation between the two?
So you're right to highlight dual diagnosis as an important issue. It's recognised in the mental health strategy. It's also in the substance use strategic commissioning and implementation plan. So we are looking at how we make the joins, and as part of that, we've made recurrent funding of about £70,000 available each year, and that's to enable the appointment of a co-occurring mental health and substance use project manager, and the recruitment for that post is underway. And we're hoping that that investment will enhance and integrate the pathways between mental health and substance use and help to address the problems that you've identified there.
Thank you. That's an important area as well that's been raised with many of us in our constituencies. Okay, you've been extremely patient. We've covered almost everything at this point. Just one thing that jumps out from an earlier point that was made at the beginning of this was in relation to, back to waiting lists again. You know, the Northern Ireland Audit Office report, which I think is a very good report, identifies the growing waiting lists in mental health, which we've already clearly identified. It's well above pre-pandemic levels, which is of concern, but that growth in waiting lists has occurred despite a significant reduction in the number of referrals accepted into mental health services. It's estimated in the reported paragraph 4.10 in the region of 20%, which is hugely significant. So the question really is, why are waiting lists growing despite a reduced number of referrals, and is that a reflection of a failure on the part of mental health services for those who are in need of that support?
Thanks for the question. I don't believe it is a sign of a failure in mental health services. I think it is a symptom of the demand and capacity gap, and for the reasons that I've explained. So referrals are down, but particularly in adult mental health, the level of accepted cases is higher now than it was. So the gap isn't as big as it looks. It's about a 10% gap in practice. And I've explained, and colleagues have also tried to explain, the big challenge here is the increased level of acuity and therefore the longer periods of treatment that individuals need when they come within the service. And that is what is taking longer, meaning that there's a slower throughput of cases because we have to, and we're absolutely right, that we meet the needs of the individuals who require these services. So that's the key challenge here, and that's what's making that apparent dislocation, as it were. I understand why you asked the question, because it looks as though, well, they're just doing less, but in practice, as I tried to explain earlier, activity levels are up by 15 and 16% in adult mental health and in psychotherapy, and that's an indication that we're doing more, but we're still not meeting the need that we have, and we recognise that there's a huge challenge, I'm afraid, not just in mental health, in relation to the waiting lists that we've got.
Okay, so appreciate your answer to that, Permanent Secretary, and it's just to seek a reassurance that it is your firm view that it doesn't reflect a reduction in performance by mental health services, but in actual fact demand has increased. That's what you're saying overall. Yes. Okay, Cheryl. Okay.
Thank you, and thank you, Chair. Basically, we've touched on it a slightly bit today, but it's just in terms, we know that vulnerable people are not getting the support they need, but other public sector organisations and departments are obviously picking this up. For example, the PSNI, there's 20,000 mental health call-outs every year, and I think they've been increasing year on year with a slight dip during COVID. So, you know, from a department's view, in terms of risk, how are you dealing with this, and what actions are you going to take going forward if the PSNI just refuse to take these calls?
So we're currently doing some work with the PSNI who are looking at the right care, right person model and how that might apply in Northern Ireland. I think there are, there's a need for us to make sure that we work this through in some detail before any steps are taken to go down that path, because there are some risks that individuals who currently they need support, and the police are the first responders, and so on. So I think it's really important that we understand that. I think it's been a core part of our policing model that policing has recognised wider dimensions of an individual's well-being as being something that is important to them, as well as obviously law enforcement, which is the core purpose. So we are engaging with the PSNI, including with the Public Health Agency, and we're looking at what they are proposing in this space and how that would work, with exactly in mind the concern that you've raised.
Okay, so that's progressing then at this stage,
yeah.
Yeah. And we've touched on again slightly through John's questions. Obviously, we know the devastating statistics. Autistic adults are 9 times more likely to die by suicide, with autistic children 20 times more likely to self-harm. Obviously, these are shocking statistics. But mental health professionals who are not trained to understand or communicate with autistic individuals are serving them at the point of contact. You know, is there anything being done within the Department of Health to address this, and making sure that we have appropriate services for people with autism or SEN?
So, obviously autism and SEN raise slightly a wider variety of questions. There is an autism strategy that's published in 2023 and designed to cover a 5-year period. There was a delivery plan published, and it's a source of regret that we've not been able to advance all aspects of that strategy to date because of funding challenges.
Is there any aspects of that?
Yes.
Yeah.
So we've been working to develop guidance for employers to increase understanding and support for autistic people in employment, in collaboration with the Equality Commission. The Housing Executive has delivered autism capacity building sessions for 400 staff with a greater understanding of the sensory environment and communication needs of autistic people. And that training has been delivered by the Department of Health and the Cedar Foundation. The Health and Social Care Leadership Centre has been commissioned to take forward work to provide proposals for the development of a regional autism information service to provide signposting to services and support. And we've also funded the development of GP training videos across all trusts to increase understanding of the challenges that autistic people experience, how reasonable adjustments can support people attending medical appointments, and so on. So, those are some of the steps that we have taken under the strategy.
And just in terms of the likes of CAMHS, for instance, or people presenting to A&E at crisis, do you take a record of those individuals if they do have autism or indeed SEN?
I don't know the answer to that question, but I'm happy to try and find it out.
Yeah, no, I think it would be important to know what the levels are, and then obviously the demand that.
And I know it's not your speciality, Dr. Claude, but do you know the answer to that?
I actually chair the ASD, the Autism Forum in the Northern Trust, so I'm reasonably...
You are the expert.
Well, there are many experts in this field. I suppose I have a reasonable understanding. One of the pieces of work that has been done within our trust, and I know similar work's been done in other trusts, through that forum and through the partnership working has been to augment the skills and training of staff who are interfacing with autistic individuals, because as you say, actually, there are types of communication that can be more effective and supportive and can be calming for those individuals at times of stress. One of the pieces of work we have done is around supporting our ED staff and various staff, including mental health staff, across our services. And I'm conscious that some of our community and voluntary partner providers have done some work around the JAM work that you may or may not be aware of, around absolutely the Just a Minute. And that approach has been found to be really helpful. So there is an increase in the use of those approaches. I don't have the answer to the question about do we keep a record in ED departments if a person arrives and is autistic. I think it's probably unlikely, but it's certainly something we can potentially come back on. But I think it's probably more important that we ensure that staff and society more generally, hotels, restaurants, shops, are all supported to develop skills of engagement with autistic individuals.
Thank you.
Chair, if I might just give a further piece of clarification.
Yes,
If we go back to children, we're currently in the process of finalising children and young people's emotional health and wellbeing framework. That framework will give a single approach to neurodevelopmental single point of referral and diagnostic pathway, and that will be going out to consultation this year. What our hope behind that is that it will standardise the referral pathway, but it'll also mean that we will move to providing help at the point of need rather than being pinned to a diagnostic confirmation of autism. So it's about getting early help at the point that someone presents. So that will be going out later this year, and hopefully that will help with regard to our children and young people.
I appreciate that. And the last question, sorry.
It's an hour and a half to go home, Chair. It takes an hour and a half to go home.
Final.
The final question. I just want to take you back to the strategy development. You just mentioned there was 400 respondents to the mental health consultation document. Is that correct? 400, yeah. I suppose from my point of view, I've looked at the consultation document. We always talk about a person-centred service. To me, I suppose there's certain barriers with that documentation for people. When we're looking at mental health, it's disproportionately affected to areas of social and economic deprivation. How can you ensure that the views and people that have went through the service are actually actively engaging with your consultation documents?
So you'll probably know the detail of this, but I imagine that we would use a number of organisations to help to engage that community. So we would tend to work through organisations to help and hold different sorts of engagement forums and so on. So that would be classically the way you would approach those problems, and I'm sure it happened in this case.
Yeah, I think it's important, as important as that is, of course, it's important to get the voices of people who have been through the services as well, and making sure that we structure.
So that was my point, though, that we work through organisations to engage people so their voices are heard and we actually get to hear them properly and they're able to express themselves.
Yeah, we use that across a range of, not just for the mental health strategy, but for a whole range of stuff. That includes the production of alternative documents in easy read format or children and young people's version or whatever. We will see what we need to do to do that. But you're right, we know we can't reach everyone ourselves, so we use our partners. Good example of working with our community voluntary partners in particular to reach the people that we need to reach.
And maybe just to note as a final point, that within trusts, within mental health services, we all have experts by experience who are service user consultants who would consult on our behalf around their perspective and the service users that they represent in terms of our area, to ensure that there's feedback. So they will have networks, and that will allow them to hear those voices, to share those voices back through us, and then they link into through SPPG, through a central coordinating point into the policy as well. So there's a myriad of ways, but it is really important, obviously, that we hear the voice of service users and of families and carers.
No, appreciate it.
Thank you, Cheryl. Thank you, Mr. May, Mr. Togut, Mr. Whittle and Dr. Carr. We do appreciate your patience and for being here, taking our questions, and I know that you take this issue very, very seriously. It is a major challenge for our population. There's no family, none of us in this room, that hasn't been touched by the challenges in mental health and the challenges faced by the service. I think it is important at this point we put firmly on record our deep appreciation to all the staff that work within the Health and Social Care Trust that do a fantastic job on a daily basis, and all of the various officials that keep the clock ticking on a daily basis and the show on the road. It does need a lot of help and a lot of work, but this inquiry, is very key to highlighting some of the very real issues that exist, and we do appreciate your time today and for your patience and sitting with us for that period.
Thank you very much. Thank you.
Thank you. Thank you.
Okay. Thank you, members. I know that was quite a lengthy session, but very important, and a lot of key areas have been highlighted. Just in this moment, Mr. Stevenson, have you anything that you'd like to raise or point out?
Chair, just a brief observation really. Again, I think the witness panel today reinforced the key message from the mental health champion last week about the importance of multi-year budgets.
Yep.
Yeah.
And that aligns well with DOF and where we would like to be on that. And I suppose it's a little trick to say sometimes that the importance of funding for essential public services, but I think given this inquiry and the importance of the subject matter, it highlights how important public expenditure exercises and budget processes are in terms of trying to strive for that optimal balance of allocations. I think those are the two key takeaways from the Department of Finance.
That's great. And thank you for being here both today as well, and for your time. We agreed multi-year budget is a major issue generally, and it's not the silver bullet, but a good starting point to resolve some of our long-term planning. Okay, members, we'll CNAG as well. Yes, sorry, the Controller and Auditor General. Have you any comments to make? You've been very quiet. Everything okay? Thank you, and thank you to you and your team also for being here. Okay, members, if agreed, we'll move into closed session. Great. Okay. Thank you.
Committee Room 21. Sound. 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 Committee Room 21. Sound.
Only about 5 minutes, do you hope?
Chair, 5 minutes, please. She got 20 minutes, she had half an hour. I'll never get it back. I'll never get that half hour of my life back.
Come on.
Joking.
NOB.
You want to go to you just go keep it closed? Yeah. Oh, members, just we'll stay in close then because we're going to discuss briefly the forward work programme, the draft forward work programme, page 89. Lucia, if you'd look at that.
Okay. Just a number of things to highlight.
Committee Room 21. Sound. 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 Committee Room 21. Sound.